Welcome to the deep dive. We're here to take really complex topics, unpack them layer by layer, and guide you towards a truly comprehensive, maybe even what you might call an elite professional level of understanding.
Hmm.
Today, we're plunging deep into the profound and honestly often startling world of ethanol.
Yeah.
Did you know, for instance, that alcohol-related deaths are the third leading preventable cause of death right here in the United States?
It's quite a statistic.
It is. That puts it just behind tobacco use and, well, poor diet and physical inactivity. It's a truly staggering fact, especially when you consider this is a substance that's been part of human culture for literally thousands of years.
It really is a compelling paradox, isn't it? When you think that alcohol, chemically, ethanol, CH3, CH2OH contributes to more morbidity, more mortality, and frankly, more public health costs than all illicit drugs combined.
Wow.
It forces us, I think, to ask a pretty critical question. How can something so widely consumed, so deeply embedded in our history, our rituals, also be so profoundly impactful and dangerous?
Yeah. That's precisely the core question we want to tackle today. You've given us a huge amount of detailed source material, and our mission for this deep dive is really to guide you through this incredibly intricate landscape.
Right.
We're going to break down its ancient history, delve into its fascinating and, let's be honest, often challenging metabolism,
Absolutely.
dissect its systemic head-to-toe effects on nearly every single organ, explore its significant impact across generations, and then finally, look at the cutting edge of diagnosis and treatment.
Yeah, the goal here is that by the end of this, you'll feel truly well-informed, equipped with the kind of detailed knowledge that, well, that really distinguishes an elite professional in this field.
We'll start by clearly defining alcohol use disorder, or AUD. Then we'll peel back the layers of the biochemistry, how your body actually processes alcohol.
Explore its widespread impact on your entire system.
Yeah.
And then finally, look at those cutting-edge treatments and the promising future outlook for managing what is a truly pervasive challenge.
Okay, let's unpack this. So to really master this topic, we've got to start with the basics, the foundational question. What exactly is ethanol?
Right.
Chemically, it looks quite simple.
Right.
CH3, CH2OH, it's a two-carbon alcohol, but, its simplicity and structure really hides its profound effects.
Mm-hmm.
One of its most defining characteristics, and really a key to understanding its rapid impact, is its incredibly swift distribution. Once it's consumed, it rapidly spreads throughout the entire body, and, crucially, it permeates the brain with remarkable speed.
That rapid distribution is absolutely critical because ethanol doesn't need, say, a specific receptor or transporter to cross cell membranes.
Oh, okay.
It can quickly diffuse into almost every tissue and fluid in the body. That includes the brain, of course. This widespread and rapid access lets it alter numerous neurochemical systems almost immediately upon reaching the central nervous system.
So it hits quick and wide.
Exactly. And this direct interaction across so many pathways is why it possesses both rewarding properties, which contributes to its recreational use, obviously, and very importantly, profoundly addictive properties. As you said, it's the oldest recreational drug known to humanity, its origins stretching back millennia. Yet when you look at the numbers, the societal cost, illness, death, public health spending, it far outstrips the combined total of all illicit drugs. It's a true paradox of human consumption.
It's a historical paradox, absolutely. And speaking of history, humans have been consuming ethanol for, well, an astonishingly long time. We've got documented evidence of its use going back as far as 10,000 BC.
Yeah, it's incredible.
Just think about that. That's a mind-boggling stretch of time. It covers nearly the entire span of recorded human civilization.
Precisely. And by around 3000 BC, the integration of ethanol into human societies was already quite sophisticated. You look at cultures like the ancient Greeks, the Romans, the inhabitants of Babylon. They weren't just using it for pleasure. They were incorporating it into profound religious festivals, even using it in medicinal practices.
Right, it had multiple roles.
It did. Over the last 2 millennia, alcoholic beverages became integrated into most cultures worldwide. It shows up in pre-Columbian America around 200 AD, even in the Islamic world by the 8th century, despite, later religious prohibitions. Its journey across civilizations really is a testament to its pervasive influence.
So it's undeniably been a global phenomenon for thousands of years.
Right.
But despite this deep cultural integration, this widespread use, what's equally fascinating is that the dangers of heavy consumption, they were recognized pretty early on by almost all cultures.
The warnings were there.
The warnings were always there, yeah. Then, fast forward to the 1800s. With the dawn of industrialization, the growing demand for a more dependable, sober workforce, organized efforts to discourage drunkenness really started to ramp up. This societal pressure eventually culminated, in the U.S. at least, in the constitutional ban prohibition from 1920 to 1933. It's a really fascinating historical pendulum swing, isn't it? Moving from something almost sacred to something outright banned.
And despite those historical records, here we are now grappling with what's formally defined as alcohol use disorder, or AUD, and it is, make no mistake, a modern epidemic on a global scale.
Right.
The 5th edition of the Diagnostic and Statistical Manual of Mental Disorders, the DSM-5, made a pretty significant shift. It integrated what used to be distinct diagnoses, alcohol abuse and alcohol dependence, into this single unified disorder, alcohol use disorder. And this approach reflects a more nuanced understanding, recognizing AUD as existing on a continuum of severity, so ranging from mild to moderate to severe. This also ties into the broader concept of substance use disorder, SUD, as a spectrum.
That continuum approach is incredibly important, I think. It helps capture the wide range of ways alcohol affects individuals, and it moves us away from that sort of rigid addict or non-addict binary thinking.
Exactly.
So to get diagnosed with AUD, a person needs to show at least 2 of 11 specific DSM-5 behaviors within a 12-month period. And the number of criteria they meet determines the severity, right?
Correct. Meeting 2 to 3 criteria indicates mild AUD, 4 to 5 points towards moderate, and meeting 6 to 11 criteria signifies severe AUD.
And those 11 criteria, they're grouped into 4 main behavioral categories to give a kind of comprehensive framework.
That's right. They provide a framework for clinical assessment. These include, first, impaired control over drinking, so difficulty limiting consumption. Second, experiencing negative social consequences because of alcohol use. Third, engaging in risky use of alcohol, like drinking in dangerous situations. And fourth, displaying altered physiological effects, specifically tolerance needing more alcohol for the same effect, and withdrawal symptoms when alcohol use stops.
And when we look at the prevalence, the sheer scale of this issue in the U.S., the numbers are truly staggering. They really underscore its impact as a major public health crisis. AUD isn't just a U.S. problem, as you said. It's one of the most prevalent psychiatric disorders globally. But right here in the U.S., back in 2019, about 14.5 million people aged 18 and older had AUD.
14.5 million.
Yeah, and the lifetime risk is incredibly high. Roughly 1/3 of men, about 36%, and 1/4 of women, 23%, will meet the criteria for a mild, moderate, or severe AUD at some point in their lives. This isn't a niche issue. It touches a huge portion of the population.
And it's crucial to note the comorbidities involved here. In the U.S., among adults, AUD is highly comorbid with other substance use disorders and various psychiatric conditions. It highlights its interconnectedness with broader mental health challenges.
Right.
Furthermore, we see clear ethnic disparities. Among ethnic groups, Native Americans, for instance, unfortunately have the highest prevalence of AUD. And the economic cost alone, it's immense. It represents a significant societal burden. Back in 2010, the estimated cost of excessive drinking in the U.S. reached about $249 billion.
Wow.
So this isn't just a health crisis. It's a profound economic drain as well.
And a major driver of all this harm and cost. A significant pattern of consumption we need to understand is binge drinking. Now, this isn't just, drinking heavily over a long period. It's specifically defined as consuming alcohol rapidly enough to reach a blood ethanol concentration, or BEC, of 0.08% or higher.
Right, the legal limit for driving in most places.
Exactly. For females, that typically means 4 or more drinks on one occasion, say within about 2 hours. And for males, it's 5 or more drinks in that same time frame.
And this pattern is incredibly impactful. Binge drinking is, in fact, the most common, the most costly, and the most deadly pattern of excessive drinking. It accounts for a staggering 77% of the total cost of excessive alcohol use in the U.S.
77%?
77. Historically, AUD and binge drinking were considerably more prevalent in men than women. But a really notable trend in the last decade has seen this difference between the sexes narrow significantly for both AUD and binge drinking.
That's interesting.
It is. And despite its immense prevalence, the morbidity, mortality, and socioeconomic costs linked to AUD, it often goes undiagnosed and untreated in clinical settings. This represents a critical public health challenge that we as professionals really have to address.
So let's dig a bit deeper into that measure, blood ethanol concentration, or BEC. This concept is absolutely fundamental if we want to understand alcohol's physiological effects at that elite professional level. It's critical to grasp that ethanol is unique among drugs because it's consumed in gram quantities.
Huge amounts, relatively speaking.
Huge amounts. This is a massive contrast to most other drugs, which typically act on very specific proteins at much, much lower concentrations, usually taken in milligram or even microgram doses. This sheer volume of intake contributes significantly to its widespread systemic effects.
That's a crucial distinction. And to put those gram quantities into perspective, think about a standard drink in the U.S. That equates to about a 12-ounce bottle of beer, maybe 4–6% alcohol by volume.
Okay.
Or a 5-ounce glass of wine, maybe 10–15%, or a 1.5-ounce shot of 40% liquor. Each of those contains roughly 14 grams of pure ethanol.
So it standardizes the actual alcohol amount. Exactly. Whether it's beer, wine, or liquor, you're getting about the same amount of actual alcohol, typically ranging from 4% to over 40% by volume. And when you see proof on a liquor bottle, that's simply twice its percentage of alcohol. So 40% alcohol is 80 proof. Simple math.
And what's truly fascinating from a practical standpoint, especially for, roadside testing, is how readily we can estimate BEC in humans.
Yeah.
Not just through blood tests, but by measuring ethanol levels in expired air.
The breathalyzer.
Right. And this isn't guesswork. It's based on a remarkably consistent partition coefficient for ethanol between blood and the air in your lungs alveoli.
Okay.
It's roughly 2100 to 1.
Which means the concentration of alcohol in your breath directly and reliably correlates to the concentration in your blood.
Yeah.
That's precisely why breathalyzers are so effective and widely used by law enforcement.
Okay.
In nearly all U.S. states, the legally allowed BEC for operating a motor vehicle is 80 milligrams per cent, often written as 0.08% weight per volume. That's 80 milligrams of ethanol per 100 milliliters of blood. That's equivalent to about 17 millimolar ethanol in the blood. And for context, what does one standard drink typically do to BEC?
Well, for a hypothetical 70-kilogram person, consuming one standard drink would typically produce a BEC about 30 milligrams per cent. But, and this is absolutely crucial to remember, this is an estimation.
Right, lots of variables.
Exactly. Your actual BEC is influenced by a multitude of individual factors. Your specific rate of drinking, your sex, your body weight, your body's percentage of water, and your individual rates of metabolism and stomach emptying. All these variables make each person's response unique.
That makes perfect sense. Your body is a complex, dynamic system, and it's definitely not one size fits all when it comes to processing alcohol. That individuality is a really key takeaway for anyone trying to understand their own response, or a patient's response. Okay, now that we understand what ethanol is, its context, and how we measure its presence, let's trace its remarkable journey through your system. This is where the body's complex, really, battle with alcohol truly begins. It starts with absorption and that initial bit of metabolism in the stomach.
Right. Once consumed orally, ethanol is absorbed remarkably rapidly into the bloodstream. It happens from both the stomach and, even more efficiently, from the small intestine. The small intestine, with its vastly larger surface area, is particularly good at this, which leads to quicker absorption compared to the stomach.
Okay.
And once absorbed, ethanol rapidly distributes into your total body water, which typically accounts for about 0.65 liters per kilogram of body weight. This rapid and wide distribution contributes significantly to its immediate effects.
And a significant factor affecting how quickly you feel those effects is gastric emptying, right? Like having food in your stomach.
Exactly. The presence of food in your stomach, for instance, can significantly delay this process, which in turn slows down ethanol absorption into the bloodstream. This explains why you often hear that drinking on an empty stomach hits you much faster. Peak blood levels can occur as quickly as 30 minutes after ingestion under those conditions.
So that strategic slice of pizza before the first drink isn't just about satisfying a craving. It's literally altering the pharmacokinetics of alcohol in your body.
Precisely. And what's really important here is this concept of first-pass metabolism. When you consume alcohol orally, the blood ethanol concentrations you ultimately reach are actually lower than if that same dose were administered intravenously.
Why is that?
Because a portion of the ethanol is metabolized before it even reaches the general circulation. This happens specifically by enzymes in both your stomach lining and, more significantly, your liver. This initial breakdown is primarily carried out by an enzyme called alcohol dehydrogenase, or ADH.
And this leads directly to a fundamental physiological difference that profoundly impacts intoxication. Those significant sex differences in metabolism.
Absolutely. Compared with males, females generally have very little gastric ADH.
Okay.
This means a smaller proportion of alcohol gets broken down in the stomach before absorption, leading to a greater amount entering the bloodstream directly. On top of that, the activity of liver ADH isozymes is typically lower in females. So females generally metabolize ethanol more slowly than males overall.
So slower breakdown and less initial breakdown.
Right. And when you combine this slower metabolism with the fact that women are generally smaller in body size and have a lower percentage of total body water compared to men, the net result is that females typically reach significantly higher blood ethanol concentrations than men after consuming the same amount of alcohol. This is a critical factor in understanding individual responses and risk profiles.
Given what you just described about first-pass metabolism, your liver truly has a Herculean task when it comes to processing alcohol. While yes, small amounts of ethanol are excreted unchanged through urine, sweat, or your breath, the vast majority, we're talking over 90%, is metabolized, primarily in the liver. It really is the body's main detox organ for alcohol.
Correct. The main enzymatic players involved in this hepatic metabolism are alcohol dehydrogenase, ADH, catalase, and a cytochrome P450 enzyme called CYP2E1. Although other CYPs like 1A2 and 3A4 might participate a bit, the primary pathway is a sequential hepatic oxidation.
Sequential oxidation
meaning it happens in steps. First, ethanol is converted to acetaldehyde by ADH. This is a key step because acetaldehyde itself is quite toxic.
Yeah.
Then, that acetaldehyde is further converted to acetic acid, essentially vinegar, by another enzyme called aldehyde dehydrogenase, or ALDH. It's a two-step detoxification process, ideally.
And here's where the kinetics, the speed of it all, become incredibly challenging for your liver. Each of those metabolic steps, ethanol to acetaldehyde and then acetaldehyde to acetic acid, requires a molecule called NAD plus UNI. That's nicotinamide adenine dinucleotide.
A crucial coenzyme.
Right. And the oxidation of just 1 mole of ethanol, which is about 46 grams, to acetic acid requires 2 moles of NAD plus ASIC. This is a massive demand that greatly exceeds the normal, readily available supply of NAD plus in the liver. So the sheer bioavailability of NAD plus actually limits how quickly your body can metabolize ethanol.
Precisely. This limitation means ethanol metabolism is relatively fixed. It occurs at a rate of about 8 grams per hour in an average 70-kilogram adult. What's fascinating about this kinetic limitation is how it changes with concentration. At higher blood ethanol concentrations, specifically above 10 milligrams percent, ethanol metabolism proceeds via what we call zero-order kinetics. This means a constant amount of ethanol is metabolized per unit of time, regardless of how much more is present. Think of it like a conveyor belt operating at its absolute maximum capacity.
They can't go any faster.
You can't go any faster. However, at lower BECs, under 10 milligrams percent, it switches to first-order kinetics. Here, a constant proportion of the remaining ethanol is metabolized per unit of time. And as we'll get into later when we discuss genetics, natural genetic variations in these ADH and ALDH enzymes can significantly influence an individual's risk for developing alcohol use disorder. What's truly fascinating here is how genetics play such a fundamental role, even at this basic metabolic level, shaping an individual's susceptibility.
That NAD plus imbalance you mentioned, the one resulting from the liver's massive effort to process alcohol, it has some really profound consequences beyond just limiting the rate of metabolism, doesn't it?
Oh, absolutely. When that hepatic NADH-NAD plus ratio gets severely thrown off, it directly impairs the function of other vital enzymes that also rely on NAD plus for their activity.
So it disrupts other processes.
It's like a metabolic traffic jam with cascading effects. This impairment leads to an accumulation of lactate, which contributes to acidosis.
Right.
It reduces the activity of the tricarboxylic acid cycle, a central pathway for energy production in your cells. And it causes acetyl-CoA, which is produced from the ethanol-derived acetic acid, to build up.
Oh.
This surplus of acetyl-CoA, combined with the increased NADH, actually promotes fatty acid synthesis and the storage and accumulation of triacylglycerides fats in the liver. This is a key mechanism in the development of fatty liver disease. Furthermore, it leads to the accrual of ketone bodies, which can exacerbate the lactic acidosis already occurring.
So it's not just about breaking down the alcohol itself, it's about a complete biochemical disruption that has these far-reaching effects on the liver's normal functions. And beyond that main metabolic road, we have this other pathway, the CYP2E1 pathway. You mentioned it accounts for only about 10% of overall ethanol metabolism, but it plays a surprisingly significant and often detrimental role.
It's a minor pathway in terms of sheer volume of alcohol breakdown, yes, but its significance lies in its interactions and its inducibility. This component of the microsomal ethanol oxidizing system is highly responsive to both acute and chronic ethanol consumption.
How so?
Well, when you acutely consume ethanol, CYP2E1 activity can actually be inhibited because ethanol itself is a substrate for this enzyme. This causes competition between ethanol and other drugs that are also metabolized by CYP2E1 common medications like phenytoin, an anti-seizure drug, and warfarin, a blood thinner. Their metabolism slows down, which can lead to increased drug levels and potential toxicity.
Okay, that's the acute effect. But here's where it gets really interesting and becomes a critical factor in understanding the chronic effects of alcohol. CYP2E1 is induced by chronic ethanol consumption.
Exactly. This induction, meaning the enzyme's activity significantly increases with chronic exposure, is the primary mechanism for the development of pharmacokinetic tolerance to alcohol. That increased CYP2E1 activity also means that other drugs that are substrates for CYP2E1 will be cleared more quickly from the body.
Meaning you might need higher doses.
Potentially, yes. A chronic heavy drinker might need a significantly higher dose of certain medications just to achieve the intended therapeutic effect, all because their body has ramped up its CYP2E1 activity due to constant alcohol exposure.
And does this heightened activity have downsides?
It does. This heightened CYP2E1 activity also has a darker side. It increases susceptibility to certain toxins. For example, it metabolizes carbon tetrachloride, a potent liver toxin, and activates it into a highly reactive radical, leading to greater liver damage from exposure. Furthermore, ethanol metabolism via the CYP2E1 pathway elevates NADP+ and limits the availability of NADPH, which is crucial for regenerating reduced glutathione, a vital antioxidant in the liver.
So it increases oxidative stress.
Significantly, it enhances oxidative stress within the liver cells.
So the overall mechanisms underlying hepatic disease, liver disease, resulting from heavy ethanol use, it's really a complex cocktail, isn't it? It's these metabolic factors, the NAD+ imbalance, compounded by CYP2E1 induction, which, as you mentioned, not only enhances toxin activation, but also generates hydrogen peroxide and other damaging oxygen radicals. And you also mentioned the potential for enhanced release of endotoxin.
Yes, harmful byproducts from gram-negative bacteria in the gut. This seems to happen as a consequence of ethanol's disruptive effects on the gastrointestinal tract, leading to increased gut permeability or leaky gut.
Right.
And to make matters worse, individuals with alcohol use disorder often suffer from poor nutritional status, malabsorption issues, deficiencies in essential vitamins like A, D, and thiamine. This, combined with suppressed immune function and a variety of other generalized systemic effects of chronic alcohol use, likely compounds these direct adverse effects, making the liver even more vulnerable to damage and disease progression. It's a multi-hit process.
Now, let's talk briefly about methanol, which you described as ethanol's dangerous chemical cousin. Methanol, also known as methyl alcohol or wood alcohol. It's an important industrial reagent, right? Found in paint removers, shellac, antifreeze.
Exactly. And it's also specifically added to industrial use ethanol precisely to make it unsafe for human consumption. A crucial deterrent, given its extreme toxicity.
How toxic are we talking?
Ingestion of as little as 8 grams, that's just 10 milliliters, less than a tablespoon of methanol, can produce severe toxicity, ranging from irreversible blindness all the way to death. What's particularly insidious is the delayed onset of symptoms. The most severe toxic effects typically take 12 hours or even more to manifest themselves.
Why the delay?
Because the toxicity is dependent on methanol being metabolized by your body into even more harmful substances.
Okay, so what exactly happens when methanol is metabolized?
First, methanol is broken down by alcohol dehydrogenase, ADH, into formaldehyde. Then, formaldehyde is further metabolized to formic acid by aldehyde dehydrogenase, ALDH. It's this formic acid that's the primary culprit behind the severe toxicity.
What does the formic acid do?
It causes direct injury to the ganglion cells of the retina and the optic nerve. This leads to profound inflammation, atrophy, and potentially irreversible bilateral blindness.
And other symptoms.
Broader symptoms of methanol poisoning include severe headaches, significant gastrointestinal distress, pain, which is partially related to pancreatic necrosis, difficulty breathing, restlessness, and blurred vision. As formic acid accumulates, severe metabolic acidosis develops, leading to respiratory depression that can become severe enough to result in coma or even death.
How is it typically absorbed?
Methanol is rapidly absorbed through various routes, via the eyes, oral ingestion, inhalation of fumes, and even through the skin. The last two routes are particularly relevant in industrial settings, obviously. Oral absorption typically occurs within 30 to 60 minutes.
And this brings us to a really fascinating and critical treatment strategy where ethanol, paradoxically, becomes an antidote for methanol poisoning. How does that work?
The fundamental basis for using ethanol in treatment is the direct competition between methanol and ethanol for the same enzyme, ADH. By giving ethanol, you effectively slow down the rate at which methanol is converted into its highly toxic metabolites like formaldehyde and especially formic acid.
You saturate the enzyme.
Exactly. You saturate the ADH enzyme with ethanol, which it prefers, thereby significantly lessening the overall toxicity and buying critical time for intervention, like dialysis.
Is ethanol the only treatment?
No, another crucial and often first-line treatment is fombosol, which is 4-methylpyrazole. Fombosol is a specific and potent ADH inhibitor. It's also used to treat methanol or ethylene glycol poisoning. It can be administered alone or in combination with hemodialysis to remove the toxins. Plasma levels of just 0.8 milligrams per liter are effective in completely inhibiting ADH.
But you wouldn't use ethanol and fombosol together.
Critically, no. Fombosol should not be used simultaneously with ethanol because it prolongs ethanol's half-life, which can lead to other complications from high ethanol levels.
Okay, and what about the acidosis?
Right. To combat the severe metabolic acidosis that inevitably develops due to that formic acid accumulation, sodium bicarbonate is a critical component of the treatment regimen. So in this dangerous scenario, a substance as common as beverage alcohol can actually be a life-saving medication. It really highlights the profound and often contradictory nature of ethanol's interaction with human biochemistry.
Now that we've established ethanol's basic chemistry, its history, prevalence, and how the body initially processes it, let's move beyond the basics and dive into ethanol's systemic impact. This isn't just about the liver or the brain, as you said. It's truly a head-to-toe exploration of its body-wide toll. Let's start with the brain, the central nervous system, which is arguably its most recognized target. Ethanol is primarily a CNS depressant, but its effects are incredibly nuanced and dose-dependent.
Absolutely. At low to moderate amounts, ethanol can have anxiolytic actions, meaning it reduces anxiety and produces behavioral disinhibition. This is where it gets really interesting and frankly a bit paradoxical. You mentioned Shakespeare earlier.
Right, the Porter scene in Macbeth. Exactly. Shakespeare's Porter, awakened from an alcohol-induced sleep, perfectly describes the acute pharmacological effects centuries before we had the science.
It's brilliant. He says, drink is a great provoker of three things. And when asked what they are, he says, Mary, sir, nose painting.
Cutaneous vasodilation causing that flushed look. CNS depression, clearly.
And urine.
Due to the inhibition of antidiuretic hormone secretion plus the fluid intake.
And then perhaps the most memorable observation. Lechery, sir. It provokes and unprovokes. It provokes the desire, but it takes away the performance. He just perfectly encapsulates the complex, often contradictory, and dose-dependent effects of alcohol on the human body and mind. He really did. Shakespeare's astute observations were remarkably accurate. As intoxication progresses to more severe levels, CNS function becomes progressively more impaired, ultimately leading to a state akin to general anesthesia. What's critical for us to understand here, especially clinically, is the very narrow margin between the concentrations that yield these anesthetic effects and those that lead to lethal outcomes, primarily due to severe respiratory depression. This narrow therapeutic window is a significant danger with high alcohol intake.
And the specific symptoms you experience and at what blood ethanol concentration depend on all those individual factors we mentioned. Body weight, body composition, rate of absorption from the GI tract.
And a key example of this individuality, again, is that for women who generally have a lower volume of distribution for ethanol due to less total body water, their BECs can be about 30% to 50% higher than men's for the exact same quantity consumed. This physiological difference means women often experience the effects more intensely and at lower doses.
So what's the typical progression?
Typically, the first signs of intoxication, characteristic of CNS depression, are observed in most people after 2 or 3 standard drinks. The most prominent effects are seen at times of peak BEC, usually about 30 to 60 minutes following consumption on an empty stomach. These initial effects can paradoxically feel stimulatory, perhaps due to an inhibition of the brain's own inhibitory systems, leading to feelings of giddiness, muscle relaxation, and importantly, impaired judgment.
But as blood levels rise, say, to around 80 milligrams per deciliter, the legal limit.
Right. Then you'll begin to see more overt signs like slurred speech, incoordination, an unsteady gait, and impaired attention. Between 80 and 200 milligrams per deciliter, the mood changes often become more intense, cognitive deficits are greater, and there's potential for increased aggressiveness and even anterograde amnesia, that alcoholic blackout, where you lose memory of events that happened while intoxicated.
And higher still.
As BECs climb above 200 milligrams per deciliter, nystagmus, those involuntary rapid eye movements, and profound sedation become pronounced. If you reach 300 milligrams per deciliter and higher, you're entering a critical danger zone with failing vital signs, coma, and potentially death due to respiratory arrest.
But you mentioned tolerance earlier. Heavy drinkers might not show these signs as clearly.
That's a crucial point for professionals. Heavy, chronic drinkers often develop significant pharmacodynamic tolerance. This means their brains adapt, and they display markedly less behavioral impairment at these same high BECs compared to someone who rarely drinks. This makes it challenging to assess their true level of intoxication based solely on observed behavior. You need the BEC measurement.
And regardless of tolerance, all these symptoms are likely to be significantly worse and occur at much lower BECs if ethanol is consumed with other CNS depressants, right? Like benzodiazepines or barbiturates or even just antihistamines.
Absolutely. This polydrug use creates a dangerous synergistic effect that can quickly lead to overdose and death. It multiplies the risk.
So when it comes to the medical treatment of acute alcohol intoxication, what's the approach?
The primary approach is really based on the severity of the respiratory and CNS depression. For less severe cases, careful observation is usually sufficient, just allowing the body to metabolize the alcohol naturally. But if there's evidence of significant respiratory depression, then intubation to protect the airway and providing ventilatory assistance are crucial life-saving measures. Stomach lavage flushing the stomach can also be considered if absorption isn't yet complete, though its utility is definitely time-sensitive.
And can you speed up the removal?
Well, because ethanol is freely miscible with water, it distributes throughout the body's water. So in severe cases of poisoning, it can actually be removed from the blood relatively effectively by hemodialysis. However, the usual protocol in the emergency room for most non-severe cases simply involves observing the patient for, say, 4 to 6 hours while their body metabolizes the ingested ethanol naturally.
And diagnostically, it's important to rule out other things.
Absolutely critical. Clinicians must differentiate profound alcohol intoxication from other conditions that can present with very similar symptoms. Things like diabetic coma, other drug intoxications, cerebrovascular accidents like strokes, or even skull fractures. Relying solely on the smell of alcohol in someone's breath can be misleading. Other metabolic conditions like diabetic ketoacidosis can produce similar odors.
So you need blood work.
Determining actual blood ethanol levels is necessary to confirm the diagnosis and rule out or identify other underlying medical conditions. And a key point to remember for professionals, there is no safe pharmacological treatment that can accelerate the rate of ethanol metabolism. We can only support the patient while the body does its own work.
Beyond the acute intoxication, chronic heavy ethanol consumption leads to these profound, often persistent brain changes and significant cognitive impairment. That familiar next morning syndrome, the hangover, the headache, thirst, nausea, hyperexcitability, cognitive fog, that might reflect a combination of initial ethanol withdrawal, dehydration, or maybe mild acidosis. It's your body basically crying for balance.
Exactly. And insomnia is another common and particularly persistent problem in alcohol use disorder, even after weeks of abstinence. This is a critical issue that must be actively treated because it significantly contributes to the risk of relapse. Makes sense. Furthermore, heavy drinking can induce or exacerbate sleep apnea, especially in older dependent individuals, due to its effects on respiration and muscle relaxation. Any treatment for insomnia in this population has to carefully take into account possible pharmacodynamic interactions with other CNS depressants, as combining them can be very dangerous.
And the cognitive impairment itself from chronic use, where does that stem from?
It seems deeply rooted in changes in synaptic plasticity, the ability of synapses, the connections between neurons, to strengthen or weaken over time. These changes affect processes like long-term potentiation and long-term depression, and they're observed in crucial brain regions like the hippocampus, vital for memory, the prefrontal cortex, critical for executive function, and the striatum and nucleus accumbens, which are part of the brain's reward system.
And it actually shrinks the brain.
It does. Chronic AUD causes measurable shrinkage of the brain due to the loss of both white and gray matter. And prolonged heavy drinking significantly increases the risk of developing a debilitating condition known as alcoholic dementia.
Is there any good news here? Is any of this reversible?
There is some good news, yes, and it's a point of hope in clinical practice. The cognitive deficits and the brain atrophy observed after a period of heavy drinking can partially reverse over the weeks to months following sustained abstinence. This really speaks to the brain's remarkable capacity for recovery, its plasticity. Similarly, Chronic alcohol abuse also reduces overall brain metabolism, a state of decreased neural activity, which typically reverses during detoxification, indicating improved brain function.
However, a more severe and often tragic neurological consequence is Wernicke-Korsakoff syndrome. You said this is a degenerative neurological disorder encompassing two related conditions, Wernicke encephalopathy and Korsakoff syndrome.
That's right. They often occur together, with most individuals developing the encephalopathy first. Some researchers even propose they might be different stages of the same underlying disorder.
And the cause is nutritional.
Primarily, yes. It's caused by a severe thiamine or vitamin B1 deficiency. It's most commonly seen in individuals with AUD, whose nutritional status is often severely compromised due to poor diet and malabsorption. However, it can also result independently of AUD from other forms of malnutrition or conditions that cause significant nutritional deficiencies.
What are the classic symptoms of the Wernicke part?
The classic triad of Wernicke encephalopathy symptoms include confusion, ataxia, that profound impairment of coordination and balance, making walking very difficult, and distinctive eye abnormalities like double vision, nystagmus, those involuntary rapid eye movements, or ophthalmoplegia, paralysis or weakness of eye muscles. Unfortunately, it's often underdiagnosed because its wide range of symptoms can overlap with so many other neurological or medical conditions.
But if it is caught early,
If caught early and treated promptly, the symptoms of Wernicke encephalopathy are usually reversible with high doses of thiamine, typically administered intravenously. However, and this is the tragic part, the severe mental impairments associated with Korsakoff syndrome, which often develops if Wernicke encephalopathy goes untreated, respond much more slowly and sadly, often incompletely.
how severe can it get?
Untreated Wernicke encephalopathy can lead to death in up to 20% of cases, and about 75% of those who survive the acute encephalopathy go on to develop Korsakoff psychosis, a chronic and truly debilitating condition.
And the psychosis involves?
That psychosis is characterized by profound memory impairment, both anterograde amnesia, the inability to form new memories, and retrograde amnesia, the loss of past memories. Patients also display marked apathy, a lack of motivation, and confabulation, where they unconsciously create false memories or stories without intending to deceive, simply to fill in the gaps.
It sounds devastating.
It is. Wernicke-Korsakoff syndrome is considered a medical emergency, emphasizing the urgency for professionals. Early treatment with intravenous thiamine, followed by oral maintenance, is absolutely essential not only to reverse the acute Wernicke symptoms, but also to prevent progression to, or at least reduce the severity of, the devastating Korsakoff state.
So let's zoom in again. On a deeper molecular level, how does ethanol unleash such widespread havoc on the brain? You said it's not really one single target.
Definitely not. Ethanol has incredible broad effects. It alters the release of numerous neurotransmitters, the brain's chemical messengers, and neuropeptides. It also modulates activity at various pre, post, and extrasynaptic sites. That means it impacts how neurons communicate before, during, and after a signal is sent, all through a really diverse array of molecular targets.
Like the reward pathways.
Exactly. For instance, even at low concentrations, ethanol significantly impacts the dopaminergic system and the endogenous opioid system. These are key reward pathways in the brain, and their modulation mediates alcohol's pleasurable and reinforcing effects. However, and this is a critical nuance for professionals, ethanol isn't believed to directly bind to and activate either opioid or dopamine receptors themselves.
Okay, so it influences them indirectly.
It influences the release and activity of these systems, creating a complex indirect effect.
And it also messes with the brain's overall balance, the excitatory-inhibitory thing?
Profoundly. It perturbs the critical balance between excitatory and inhibitory transmission. Think of your brain having gas pedals and brake pedals for neural activity. Alcohol essentially slams on the brakes for your excitatory systems while simultaneously hitting the gas on your inhibitory ones.
How does it do that?
Specifically, it enhances the function of inhibitory cis-loop ligand-gated ion channels, such as GABA and glycine receptors, which typically slow down brain activity. Concurrently, it inhibits the function of excitatory inotropic glutamate receptors, like N-methyl D-aspartate, NMDA, amino-3-hydroxy-5-methyl-4 isoxazoyl propionic acid, AMPA, and kainate receptors. These are crucial for quick excitatory signaling.
So more inhibition, less excitation.
Broadly speaking, yes. And beyond these major players, other critical channels such as GRK channels, G-protein-coupled inwardly rectifying potassium channels, 5-HT3 serotonin receptor-gated channels, and L-type K2+ channels are also notably sensitive to ethanol even at low concentrations.
Have we found specific binding sites?
Researchers have identified putative ethanol binding sites within many of these channel proteins through advanced molecular modeling of high-resolution crystal structures. But, and this is a key distinguishing feature of ethanol, unlike many other drugs with very specific high-affinity targets, it has a relatively weak affinity for its molecular targets.
That seems counterintuitive. Weak affinity, but strong effects.
It does, but paradoxically, this weak affinity, coupled with the ease with which ethanol is distributed and diffuses through cell membranes, actually broadens its targets and amplifies its long-term neurobiological effects, rather than limiting them. This means that despite decades of research, the precise molecular mechanisms responsible for alcohol intoxication, its rewarding properties, and the profound state of dependence remain surprisingly complex and, in many aspects, still poorly understood.
So when we consider all this molecular complexity, what does this actually mean for our understanding of addition itself, of AUD?
That molecular complexity, coupled with the systemic effects we're discussing, fundamentally underscores why alcohol use disorder is characterized as a chronically relapsing and compulsive use of alcohol. It's not a single event, but a progressive disease that unfolds through three interacting stages, each with distinct neurobiological underpinnings that progressively worsen over time.
What are those stages?
They are the binge intoxication stage, the withdrawal negative affect stage, and finally the preoccupation anticipation or craving stage.
Okay, let's break those down as they really form the blueprint of AUD progression. First, the binge intoxication stage. You said this is primarily mediated by the neurocircuitry of the basal ganglia.
That's right, a group of subcortical nuclei in the brain. This circuitry is responsible for facilitating incentive salience, which is a form of motivational salience associated with the intense feeling of reward. It's what makes a certain experience feel highly desirable and drives you towards it, makes it wanted.
And the basal ganglia are involved in habits too, right?
Crucially, they're involved in voluntary motor control and, importantly, procedural learning related to routine behaviors or the formation of habits. In this binge intoxication stage, the release of key neurotransmitters, dopamine and endogenous opioid peptides, in the ventral striatum, particularly the nucleus accumbens, is strongly associated with the reinforcing actions of alcohol. This is the brain's reward center signaling pleasure.
Any other systems involved?
Yes. Endocannabinoid signaling may also contribute to the motivational and reinforcing properties of ethanol. Research shows that ethanol drinking alters endocannabinoid levels and cannabinoid receptor 1 expression in crucial brain nuclei within these addiction pathways.
So alcohol essentially hijacks the brain's natural reward system. It imparts this intense motivational property to things associated with drinking, things that were previously neutral.
Exactly. And this initial activation of the ventral striatum then leads to the recruitment of what are called basal ganglia globus, pallidus thalamic cortical loops. These complex loops engage the dorsal striatum, a region of the brain hypothesized to be the very beginning of compulsive-like responding for drugs. It's the transition from seeking pleasure to developing a habit.
And this stage is also where tolerance begins to rapidly develop to alcohol's rewarding effects.
Yes, tolerance is a critical concept in addiction. It's defined as that reduced behavioral or physiological response to the same dose of drug, or, conversely, the requirement of a higher dose to obtain the same desired effect. This phenomenon can be pharmacokinetic, how the body processes the drug, or pharmacodynamic, how the drug affects the body at the cellular level.
You mentioned the Mellanby effect, acute tolerance.
Right, that's acute or functional tolerance. It occurs within hours of alcohol administration and is due to rapid CNS adaptations. This is why behavioral impairment and subjective feelings of intoxication are often much greater at a given BEC when your blood alcohol is rising on the ascending limb of the curve than when it's falling on the descending limb, even at the exact same concentration. Your brain is already adapting very quickly.
And then there's chronic tolerance.
Right, which develops in long-term heavy drinkers. In contrast to acute tolerance, chronic tolerance involves both pharmacodynamic and pharmacokinetic elements. The latter, the pharmacokinetic component, is primarily due to the induction of those alcohol metabolizing enzymes, especially CYP2E1, which we discussed earlier. In some cases, this maximum pharmacokinetic tolerance can actually double your normal metabolic rate.
Meaning you need to drink twice as much for the same effect.
Potentially, yes. It requires significantly more alcohol to achieve the same effects experienced previously.
Okay, so that's stage one. What's the second critical stage of AUD?
The second stage is the withdrawal negative effect stage. Dependence is clinically defined by the emergence of a withdrawal syndrome, which is observed anywhere from several hours to days after alcohol consumption is terminated. The specific symptoms and their severity are directly determined by the amount and duration of the chronic drinking.
And these symptoms are far more than just discomfort, right? They include significant motivational changes, profound sleep disruption.
Intense activation of the autonomic nervous system, leading to symptoms like rapid heart rate, sweating, tremors, and, in severe cases, life-threatening seizures.
And delirium tremens, or DTs.
That's the most severe form. It can occur 2 or more days after withdrawal begins. Individuals experiencing DTs may suffer from terrifying hallucinations, severe delirium, extreme tachycardia, rapid heart rate, and a potentially fatal fever or cardiac arrhythmia. It's a true medical emergency.
And it's not just the acute physical symptoms. There are persistent negative emotional states, too.
Yes, and this is crucial. Individuals with AUD often show evidence of persistent negative emotional states during acute withdrawal that can unfortunately persist into protracted abstinence, sometimes for weeks or even months. These states include significant anxiety, dysphoria, that profound state of unease or dissatisfaction, and depression. These persistent anxiety and depression-like symptoms are extremely important clinical considerations as they heavily contribute to the risk of relapse.
Managing delirium tremens, you said, is a medical emergency. Requires intensive care?
Absolutely. An intensive care unit or another inpatient setting is necessary. Patients must be kept in a quiet, comfortable environment with routine vital sign monitoring. It's also crucial to immediately correct any electrolyte, fluid, and nutritional deficiencies, which are almost always present.
What are the treatments?
Long-acting benzodiazepines, such as diazepam or chlordiazepoxide, are the treatments of choice to manage symptoms and prevent seizures. But other agents like phenobarbital, dexmedetomidine, or propofol may be used in patients who are refractory, meaning unresponsive to benzodiazepines. It's also vital to consider common comorbidities, especially liver dysfunction, which can significantly affect benzodiazepine dosing regimens. And lastly, the clinical management of DTs would be incomplete if it's not done in the context of anticipated long-term treatment of the patient's underlying alcohol use disorder. You have to treat the immediate crisis and plan for the long term.
So what's the neurobiological basis for this really distressing withdrawal negative affect stage?
It's understood to involve 2 primary processes. First, a decreased functioning in the brain's reward systems, particularly in the ventral striatum, which makes everyday activities feel less pleasurable, a state called anhedonia. Second, there's a significant recruitment and activation of stress systems in the extended amygdala.
Stress systems take over?
Essentially, yes. As dependence develops, powerful brain stress systems involving key neuropeptides like corticotropin-releasing factor, CRF, and neurotransmitters like norepinephrine and dynorphin become increasingly active. This recruitment produces a powerful, almost inescapable motivation for drug seeking, driven not by seeking pleasure anymore, but by the desperate need to alleviate the profound physical and emotional discomfort of withdrawal.
This relentless drive leads us directly to the third and final stage, preoccupation anticipation, often just called craving. This stage fundamentally involves a dysregulation of the prefrontal cortex circuits, the brain's executive control centers. This dysregulation leads to a significant loss of that executive control over behavior.
All right. In the AUD brain, the ability to complete complex tasks, weigh consequences, and make rational choices becomes profoundly impaired. It's thought to involve a critical imbalance between 2 opposing systems within the prefrontal cortex.
A go system and a stop system.
That's a good way to put it. There's typically a go system, primarily located in the anterior cingulate cortex and dorsolateral prefrontal cortex, which engages habits via the basal ganglia, the habit formation center. This system drives automatic, often compulsive behaviors. Simultaneously, there's normally a stop system involving the ventrolateral prefrontal cortex and orbitofrontal cortex, which is supposed to inhibit the basal ganglia's incentive salience, the wanting, and dampen the extended amygdala's stress system, the suffering. However, in AUD, this stop system is significantly weakened.
So the brakes fail.
The brakes fail. This weakened stop system means individuals with AUD often show significant impairments in decision-making, spatial information processing, and behavioral inhibition, all executive functions crucial for making rational choices and resisting impulses. These impairments are key drivers of craving.
And craving itself isn't monolithic. There are different types.
That's right. Craving can be broadly divided into 2 types. Reward craving, which is drug seeking induced by the drug itself or by stimuli linked to the drug, like seeing a bar, smelling alcohol, certain social situations, and relief craving, which is drug seeking induced by an acute stressor or a state of chronic stress, where alcohol is sought primarily to alleviate emotional pain or withdrawal symptoms.
So deficits in the prefrontal cortical control over both the basal ganglia's go signals and the extended amygdala stress signals. That might explain individual differences in susceptibility and why addiction becomes so entrenched.
Exactly. The residual dysregulation of these specific neurocircuits, which mediate incentive salience and stress responsivity, plays a crucial role in perpetuating compulsive drug taking and dramatically increases the risk of relapse, even after long periods of abstinence. It truly is a vicious cycle built directly into the brain's very wiring by chronic alcohol exposure, making recovery an uphill battle that requires deep understanding and targeted, often long-term, intervention.
Okay, so far, we've focused heavily on the brain, which makes sense given addiction's nature. But for that truly professional, comprehensive understanding, we absolutely must acknowledge that ethanol's impact extends far, far beyond the central nervous system. It takes a profound, body-wide toll, affecting nearly every organ system. Let's broaden our scope now and begin with the endocrine system, the body's master hormonal regulator.
Yes, the endocrine system, this complex network of glands producing and secreting hormones directly into the blood, is absolutely essential for maintaining homeostasis, the body's internal balance. These hormones affect almost every cell and organ, regulating a myriad of processes: metabolism, energy balance, electrolyte balance, stress response, growth, development, reproduction.
And communication between systems.
Yes, it also plays a crucial role in controlling communication between the immune and nervous systems. It's fundamental.
And alcohol profoundly disrupts this delicate balance. Both acute and chronic ethanol consumption differentially alter endocrine function through multiple hypothalamic pituitary axes. That includes the adrenal axis, stress, the gonadal axis, reproduction, the thyroid axis, metabolism, the growth hormone IGF-1 axis, growth repair, and the posterior pituitary axis, water balance.
That's right. Furthermore, chronic ethanol intake specifically disrupts hormones from the endocrine portions of the pancreas, like insulin and glucagon, and adipose tissue, like leptin, and it affects the pituitary hormone prolactin, often causing a condition called hyperprolactinemia, too much prolactin in the blood.
And these widespread hormonal disturbances, they contribute significantly to a whole host of serious medical conditions, don't they?
They absolutely do. They are implicated in the development and progression of thyroid disease, cardiovascular disease, immune dysfunction, reproductive dysfunction, various cancers, diabetes, and they can even exacerbate underlying psychological disorders. The endocrine system's disruption by ethanol creates this systemic cascade of negative health consequences, affecting almost every physiological process.
This brings us directly to sexual and reproductive function. There's that widespread popular misconception that alcohol enhances sexual function, maybe due to its initial disinhibiting effects.
Right, the idea it lowers inhibitions and increases libido.
But as we heard from Shakespeare's Porter ages ago, the reality is generally quite the opposite.
That's absolutely correct. While some might experience that initial disinhibition, the overall effect of chronic alcohol use on sexual function is generally detrimental. Sexual dysfunction in alcohol use disorder frequently includes decreased sexual arousal, increased ejaculatory latency, meaning it takes longer to ejaculate, and decreased orgasmic pleasure.
And fertility issues.
Yes, that condition we just mentioned, hyperprolactinemia caused by chronic ethanol intake, can significantly decrease fertility in both men and women with AUD. This occurs by leading to hypogonadism, reduced function of the gonads, decreased sperm production in men, impotence, and menstrual cycle irregularities in women. Ethanol's direct adverse effects on the hypothalamic pituitary gonadal axis also contribute to these diminished libido and fertility issues, alongside gonadal atrophy and persistent menstrual irregularities.
Moving now to bone health. Maintaining strong bones requires this meticulously balanced bone remodeling process where old bone is continuously removed by cells called osteoclasts and new bone is formed by cells called osteoblasts. Chronic heavy drinking profoundly disrupts this delicate equilibrium. How?
It disrupts the balance by inhibiting bone formation, slowing down the osteoblasts, and simultaneously interfering with bone resorption, the process driven by osteoclasts.
And this is particularly concerning during specific life stages.
Yes, particularly during adolescence and in young adults, when peak bone mass is still being achieved. Binge or heavy drinking during these critical developmental periods can dramatically compromise long-term bone health. As a direct consequence, with decreased bone mass and reduced bone mineral density, the risk of developing osteoporosis, where bones become brittle and fragile, and sustaining painful fractures significantly increases, often disproportionately for a person's age.
And it's not just the direct effects on bone cells?
No, there are also crucial indirect mechanisms at play. These include poor vitamin D metabolism and impaired calcium absorption, both absolutely vital for bone health. Furthermore, hormonal deficiencies common in men and women with AUD are significant contributing factors. For example, testosterone, an anabolic hormone crucial for osteoblast production, is often decreased. Reduced estrogen levels can increase bone fragility, particularly in postmenopausal women, but also premenopausally. And elevated levels of cortisol, the stress hormone, and parathyroid hormone, often seen in AUD, also contribute to decreased bone formation. It's really a multifaceted attack on bone integrity.
Ethanol also has a notable and perhaps counterintuitive impact on body temperature. You ingest alcohol, and you might experience an initial feeling of warmth.
Yes, that sensation is due to enhanced cutaneous vasodilation. Your blood vessels near the skin surface widen, allowing more blood to flow there, making the skin feel warm.
But this warmth is misleading.
Very misleading. It's simply heat being transferred from your body's core out to the periphery. As a result, your core body temperature actually falls because ethanol directly affects the central temperature regulating mechanism located in your hypothalamus, effectively resetting your internal thermostat downwards.
And this seemingly innocuous effect can actually turn dangerous.
Absolutely. Intake of high quantities of ethanol may lead to pronounced decreases in core body temperature, especially when combined with cold ambient temperatures. Alcohol is, in fact, a major risk factor contributing to deaths from hypothermia, because individuals may not perceive how cold they truly are due to that feeling of surface warmth, leading to dangerous exposure. It's a critical point for public health awareness. Alcohol doesn't warm you up, it makes you feel warm while actually dropping your core temperature, increasing risk.
Shifting to the kidneys, another vital organ system. Ethanol exerts its effects here primarily by inhibiting the release of vasopressin.
Right, vasopressin, also known as antidiuretic hormone, or ADH, not to be confused with alcohol dehydrogenase. This hormone comes from the posterior pituitary gland.
Okay. And vasopressin normally tells the kidneys to reabsorb water.
Exactly, it concentrates the urine. By inhibiting its release, ethanol results in enhanced diuresis, meaning you produce significantly more urine than the volume of fluid you consumed. This dehydrating effect is a common contributor to the familiar headache and nausea associated with a hangover.
But interestingly, the effects reverse during withdrawal.
They do. Alcohol-dependent individuals undergoing withdrawal exhibit an increase in vasopressin release. This leads to a consequential retention of water, which can manifest as edema or swelling, and in some cases, dilutional hyponatremia, a dangerously low sodium level in the blood due to excess water retention. It's a complete flip in fluid balance once dependence sets in.
Now, the cardiovascular system, this seems to have a really complex, almost paradoxical relationship with ethanol consumption. Cardiovascular disease is a leading cause of death and disability globally.
And heavy alcohol use unequivocally and significantly increases the risk for these conditions. That part is clear.
However, this is where the nuance and maybe some controversy comes in. Some observational studies have suggested a lower risk of cardiovascular disease in light to modest drinkers, but you've urged caution.
Yes, and this is a major caveat for professionals. This perceived benefit may simply be a product of healthier lifestyles already prevalent in this particular group of light drinkers. They might exercise more, eat better, etc. Clinicians' drinking recommendations must remain guarded given that the risk is highly dependent on dose and many other individual factors, sex, age, specific drinking patterns, other lifestyle factors. Genetic risk play a huge role. Furthermore, there is a critical lack of randomized controlled trials on ethanol's long-term effects on cardiovascular function, making definitive conclusions about causality really challenging. Correlation is not causation here.
That caution seems very well placed. However, on a more specific note regarding serum lipoproteins, low alcohol consumption might have some beneficial effects.
It may. Low alcohol consumption can increase high-density lipoprotein cholesterol, HDL, often called the good cholesterol. HDL plays a crucial role in reverse cholesterol transport, moving cholesterol from peripheral tissues back to the liver for elimination. It might also decrease total cholesterol, triglycerides, and low-density lipoprotein cholesterol, LDL, the bad cholesterol that causes plaque buildup in arteries. This overall decrease in cholesterol accumulation in arterial walls could contribute to a decreased risk of cardiovascular disease. But again, the overall risk-benefit equation for population health is still heavily debated, especially given alcohol's other harms.
But then when we look at hypertension, high blood pressure, and stroke, the picture seems to shift pretty clearly towards harm at higher doses.
Yes. In general, alcohol-risk relationships for hypertension tend to be J-shaped in women, maybe suggesting a decreased risk at very low doses. However, based on comprehensive meta-analyses, women drinking more than 20 grams of ethanol per day, about 1.5 drinks, and men drinking more than 30 grams per day, about 2 drinks, consistently showed an increased risk of hypertension. And even small, chronic increases in blood pressure can significantly increase mortality from coronary artery disease and from stroke over time.
And for stroke specifically.
The data suggests that approximately 1 to 2 drinks per day may have no effect or even slightly reduce stroke events in both men and women. But critically, beyond that modest level, greater daily alcohol consumption definitely and demonstrably increases overall stroke risk. This really highlights the importance of dose and the pattern of consumption. Heavy drinking is clearly detrimental.
Beyond hypertension and stroke, cardiac arrhythmias are also a serious concern. Atrial fibrillation, AFib.
Right. Atrial fibrillation, AF, is a common and dangerous arrhythmia characterized by an irregular and often rapid heart rate. AF is a significant consequence of consuming large amounts of alcohol, particularly during binge drinking episodes, which are known to trigger what's sometimes called holiday heart syndrome. AF is one of the most common sustained arrhythmias and is strongly associated with serious cardiovascular events, most notably stroke, because it can allow blood clots to form in the heart.
And then there's alcoholic cardiomyopathy. This is an acquired form of heart muscle disease.
Yes, an acquired form of dilated cardiomyopathy, specifically associated with long-term heavy alcohol consumption. It is characterized by a dilated, weakened left ventricle, an increased heart muscle mass, and often reduced ejection fraction, the percentage of blood pumped out with each beat in advanced stages. It's essentially heart failure caused by alcohol.
What are the mechanisms behind that?
They're complex and likely multifactorial. They involve oxidative stress damaging the heart cells, direct cell death, apoptosis, impaired mitochondrial function, compromising cellular energy production within the heart muscle, altered fatty acid metabolism and transport, and increased protein breakdown within heart muscle cells. All these factors contribute synergistically to the weakening and enlargement of the heart muscle over time.
Now let's turn our attention to the lungs. You mentioned these are often overlooked as a primary site of ethanol action, yet they suffer significant consequences.
Absolutely. Individuals with alcohol use disorder are significantly more susceptible to developing a range of serious pulmonary infections, including pneumonia, tuberculosis, and respiratory syncytial virus, RSV infection. Furthermore, they are at a much higher risk for developing acute respiratory distress syndrome, or ARDS.
And ARD is very serious.
It's extremely serious. It's a severe and often deadly lung condition characterized by widespread inflammation and fluid buildup, even in otherwise healthy individuals. But someone with AUD is at an even greater risk, with significantly higher mortality rates if they develop AOD. And what's particularly concerning for professionals is that AOD can occur relatively quickly, even in young AUD patients, whereas something like cirrhosis typically takes many years of chronic drinking to develop.
What causes this increased susceptibility in the lungs?
It's caused by profound impairment of the body's immune responses, specifically within the lungs. For example, alcohol directly impairs neutrophil production, and released neutrophils are key infection-fighting white blood cells. It impairs lymphocyte function, particularly T-cell function. It reduces ciliary function in the airways, compromising the natural clearance of pathogens and mucus. And it impairs the function of alveolar macrophages, the critical immune cells that reside in the air sacs, alveoli of the lungs, and act as first responders.
So in essence, the alcoholic lung is fundamentally immunocompromised and under severe oxidative stress.
Exactly. It becomes depleted of vital antioxidants like glutathione, rendering it a weakened defense system. This makes these individuals far more vulnerable to respiratory illnesses and the potentially fatal complications of even common infections.
Moving from the lungs to skeletal muscle, you said dysfunction here, specifically myopathy, is actually very common in alcohol use disorder.
Surprisingly common, yes. Despite its high prevalence, affecting approximately 50% of chronic drinkers, it often goes unrecognized in clinical practice. To put it in perspective, alcoholic myopathy is about 5 times more common than the incidence of liver cirrhosis, yet it receives far less attention. Myopathy can significantly worsen the overall clinical outcome for patients, and the presence of liver cirrhosis itself may also influence its development.
And it involves muscle wasting.
Yes, the decreased muscle mass observed in alcohol-induced myopathy results from a profound imbalance in protein synthesis and degradation within the muscle cells. Specifically, there's a documented decrease in the synthesis of myofibrillar and sarcoplasmic proteins, which are the core structural and functional components of muscle.
What are the mechanisms behind that imbalance?
Some of the specific anabolic building up and catabolic breaking down mechanisms implicated seem to involve decreased signaling through the mammalian target of rapamycin, mTOR, pathway, which is a key regulator of protein synthesis and muscle growth. Simultaneously, there's evidence of excessive protein degradation via the ubiquitin-proteasome pathway and the autophagic lysosomal system. These are cellular recycling and waste disposal systems that become overactive and break down muscle proteins too rapidly.
Is there potential for recovery here?
Yes, and this is important for patients and clinicians. Functional improvements in muscle strength could occur over time following sustained abstinence or even significant reduction in drinking. Optimizing nutritional status through balanced diets and potentially vitamin supplementation can also significantly improve muscle function and aid in recovery, highlighting the importance of holistic care in AUD.
Now let's turn our attention to the digestive system, which seems to bear a truly heavy burden from alcohol right from the moment it's ingested.
It absolutely does. Your body prioritizes metabolizing alcohol over many other functions. As ethanol is absorbed and processed, it can directly damage nearly all organs of the digestive system and significantly increase the risk of several cancers along the way. Heavy drinking damages the mucosal lining of the esophagus, stomach, and intestines. It disrupts crucial gastric and intestinal barriers. It impairs the absorption of vital nutrients and proteins. It compromises immune responses within the gut. And it directly causes conditions like gastritis, pancreatitis, and various liver diseases.
And you mentioned gut dysbiosis.
Yes, the severe imbalance in the composition of your gut microbiota caused by ethanol has widespread inflammatory consequences that ripple throughout the entire body, impacting systems far beyond the gut itself.
Okay, let's break that down, starting with the esophagus and stomach.
Right. Ethanol directly damages the delicate mucosal lining in both. Functionally, it lowers esophageal sphincter pressure, which can lead to acid reflux, GDRD. It impairs motility, slowing down the movement of food, and it alters gastric acid secretion, sometimes increasing it, sometimes decreasing it.
Leading to conditions like
Patients with AUD commonly develop gastroesophageal reflux disease, GERD, peptic ulcers, or acute and chronic gastritis, inflammation of the stomach lining. Heavy drinking is also a significant predisposing factor for Mallory-Weiss syndrome, those serious mucosal tears at the gastroesophageal junction, where the esophagus meets the stomach, which can lead to life-threatening upper GI bleeding.
how are these typically treated?
Often with pharmacological interventions like proton pump inhibitors, PPIs, and histamine H2 antagonists, H2 blockers, which are used to decrease gastric acidity and allow the damaged mucosa to heal.
And moving down to the intestines.
Ethanol damages the intestinal mucosa here too, both directly and indirectly. Indirectly, by altering the delicate balance of the gut microbiota and impairing crucial mucosal immune function.
And this leads to symptoms like chronic diarrhea.
Very commonly, yes. Many individuals with AUD suffer from chronic diarrhea, which is largely caused by malabsorption in the small intestine due to structural and functional changes. For example, the intestinal mucosa often exhibits flattened villi, those tiny finger-like projections essential for nutrient absorption, and digestive enzyme levels are frequently decreased. The associated rectal fissures and pruritus anni, anal itching, that are sometimes linked to heavy drinking are likely related to this chronic diarrhea.
Are these intestinal changes permanent?
Fortunately, no, not usually. It's an important point that these intestinal changes and symptoms are usually reversible after a period of sustained abstinence, highlighting the gut's remarkable capacity for recovery once the toxic insult of alcohol is removed.
Okay, now the pancreas. This is another major target for alcohol-induced damage. You said heavy alcohol use is the most common cause of both acute and chronic pancreatitis in the U.S.
It is. Acute alcoholic pancreatitis is characterized by the abrupt onset of severe abdominal pain, often radiating through to the back, accompanied by nausea, vomiting, and significantly increased levels of pancreatic enzymes, like amylase and lipase, in the serum or urine.
How is the acute form treated?
Treatment for acute pancreatitis typically consists of supportive care. Intravenous fluid replacement, often with nasogastric suction to rest the pancreas and relieve pressure, and opioid pain medication to manage the often excruciating pain. Nothing by mouth is usually enforced initially.
And chronic pancreatitis, how does that develop?
Similar to alcoholic cirrhosis in the liver, chronic pancreatitis results from progressive cellular destruction and fibrosis, scarring within the pancreas. It typically develops after recurrent episodes of acute pancreatitis, although sometimes it can develop more insidiously. The mechanism involves ethanol metabolites and byproducts like reactive oxygen species directly injuring pancreatic acinar cells, which are the cells responsible for producing digestive enzymes. This injury causes specialized cells, called stellate cells in the pancreas, to become activated and produce excessive extracellular matrix proteins, leading to the atrophy and fibrosis that characterizes chronic pancreatitis.
You mentioned something interesting earlier about non-oxidative metabolism in the pancreas, FAEEs.
Right. Compared with the liver, the ability to oxidize ethanol in the pancreas is relatively low. However, during chronic alcohol abuse, the pancreas has a much greater capacity than the liver for non-oxidative metabolism of ethanol, converting it into substances called fatty acid ethyl esters, or FAEEs. There is a hypothesis that the inhibition of hepatic ADH during chronic drinking and the resulting increased production of these FAEs within the pancreas may be a major mechanism in the complex pathogenesis of chronic pancreatitis. These FAEs are thought to be directly toxic to pancreatic cells.
And the symptoms of chronic pancreatitis.
The main clinical symptoms are persistent, often debilitating pain, significant malnutrition due to malabsorption, because the pancreas isn't producing enough digestive enzymes, and the development of diabetes mellitus, as the endocrine function of the pancreas, insulin production, is also progressively damaged. Patients may require insulin to control hyperglycemia and also need pancreatic enzyme replacement therapy capsules containing lipase, amylase, and proteases to treat the malabsorption and aid digestion.
And then, of course, there's the liver. As the main organ involved in ethanol metabolism, it's the well-known primary target for the pathological effects of chronic ethanol consumption. The statistics are stark.
They are. According to the CDC, back in 2018, approximately 43% of all deaths due to liver disease among individuals aged 12 and older involved alcohol, making it a leading cause of liver-related mortality in the U.S.
And the damage progresses through distinct stages over time.
Yes, the effects are dose-dependent and typically progress through stages. It starts with fat accumulation, known as ketosis, or fatty liver, which can develop remarkably quickly, sometimes in just a few days of heavy drinking. This can then progress to fatty liver, accompanied by inflammation, called steatohepatitis, sometimes abbreviated as ASH alcoholic steatohepatitis. Further progression leads to collagen deposition, or fibrosis, scarring, and finally to widespread fibrous scarring and loss of functional liver cells, which is cirrhosis. It's important to note, however, that some heavy drinkers can unfortunately develop cirrhosis without first developing obvious hepatitis, highlighting the varied and sometimes unpredictable nature of disease progression.
What's the mechanism behind that initial fat accumulation, the steatosis?
It's complex, but rooted in metabolism. Ethanol perturbs most aspects of hepatic lipid metabolism. The generation of that excess NADH, produced via the metabolism of ethanol and acetaldehyde by ADH and ALDH, inhibits the tricarboxylic acid cycle, a key energy pathway, and simultaneously reduces the oxidation burning of fats for energy. This metabolic shift leads directly to the accumulation and storage of fat, triglycerides, in the liver cells.
And the cirrhosis, the severe scarring.
Fibrosis, which results from chronic tissue necrosis cell death and persistent inflammation, is the underlying cause of alcoholic cirrhosis. While fatty liver disease is extremely common in those with AUD, thankfully, only a minority will unfortunately progress all the way to cirrhosis. Why some do and others don't is still an area of intense research, likely involving genetic and environmental cofactors.
You also mentioned the gut-liver axis being important here.
Yes, this is a critical and relatively newer area of understanding. Patients with alcohol-related liver disease consistently show significant changes in the composition of their gut microbiomes, dysbiosis, alongside increased intestinal permeability, that leaky gut. This allows increased circulating levels of gut-derived microbial endotoxin, specifically LPS, lipopolysaccharide, from gram-negative bacteria, to reach the liver via the portal vein. LPS is a potent trigger for steatosis, inflammation, and fibrosis in the liver. It does this by stimulating the generation of reactive oxygen species and initiating a cascade of events that culminate in the transcription of pro-inflammatory cytokines, essentially fueling the fire of liver damage.
What's the prognosis? Can the liver recover?
The prognosis and reversibility vary greatly depending on the stage. Fatty liver disease and acute alcoholic hepatitis are usually reversible with sustained abstinence from alcohol. The liver has a remarkable capacity for regeneration if the insult stops early enough. However, in severe cases of alcoholic hepatitis or full-blown cirrhosis, while abstinence may stop or delay further disease progression, the cirrhosis itself, The extensive scarring is usually irreversible and often a terminal condition if the patient does not receive a liver transplant. This underscores the critical importance of early detection and intervention before irreversible damage occurs.
Alcohol also has significant hematological effects, impacting your blood and its components.
Yes, while nutritional deficiencies, which are common in AUD, certainly play a role in various alcohol-related anemias, alcohol also directly interferes with red blood cell production in the bone marrow. Heavy drinking is associated with different types of anemias, such as macrocytic anemias, where red blood cells are abnormally large, and sometimes sideroblastic anemias, where iron isn't incorporated properly into hemoglobin.
What about other blood components? Platelets, white blood cells.
Thrombocytopenia, which is a low platelet count, is quite common in heavy drinkers and can complicate the already challenging alcohol withdrawal syndrome by increasing the risk of bleeding or bruising. Leukopenia, a low white blood cell count, is also frequently found in AUD, and this significantly increases susceptibility to various infections, as white blood cells are, of course, crucial for the immune response.
This naturally leads us to the broader impact on the immune system itself. You're saying ethanol profoundly disrupts both innate and adaptive immune signaling.
It does. This disruption not only further increases the risk of infection, as we've seen with the lungs and white blood cells, but it also causes systemic inflammation that can damage organs throughout the body and significantly increase cancer risk. Indeed, compromised immune responses are now understood to be central to the pathogenesis of alcoholic liver disease, among many other alcohol-related conditions.
How does it affect specific immune cells?
In addition to impacting granulocytes, like neutrophils leading to leukopenia, ethanol alters lymphocyte composition. Lymphocytes are crucial white blood cells like T cells and B cells. It decreases T cell mitogenesis, meaning T cells are less able to multiply and mount a response to threats. It also changes immunoglobulin production, affecting the body's antibody response mediated by B cells.
So, overall weakened resistance to infections.
Exactly. Individuals with AUD have a significantly weakened resistance to common and severe infections, such as Klebsiella pneumonia and tuberculosis. We mentioned how the function of crucial immune cells like alveolar macrophages and neutrophils in the airways is impaired, causing damage that might not even be evident until the patient encounters a secondary respiratory infection, leading to much worse outcomes.
And that gut-bloodstream link is important here too.
Critically important. As a direct consequence of ethanol's harmful effects on the gut microbiome and the integrity of the gastrointestinal tract barrier, gut microbes and their toxic byproducts, like LPS, can escape from the gut into the bloodstream. Once in the systemic circulation, these microbes and their components go on to trigger or exacerbate widespread immune and pro-inflammatory responses in various tissues and organs throughout the body, including the liver, brain, and elsewhere.
So the immune dysfunction isn't just peripheral, it affects the brain too.
That's right. The immune dysfunction is not confined to peripheral injury or illness. There's growing evidence of its impact on the central nervous system, leading to neuroinflammation. It's still not entirely clear whether peripheral inflammatory responses are required to induce neuroinflammation, or if ethanol also has direct pro-inflammatory effects within the brain itself. It's likely a combination.
This leads us to the neuroimmune system. You said the impact of immune signaling in the brain on the neurobiological and behavioral changes in AUD has been a major focus recently.
Yes, over the past decade especially. Chronic ethanol consumption increases the levels of circulating innate immune signaling molecules, such as those pro-inflammatory cytokines we mentioned, like TNF-alpha, IL-1 beta. These cytokines are capable of crossing the blood-brain barrier and reaching the brain parenchyma.
And once in the brain?
Once in the brain, these circulating immune molecules, along with immune molecules produced locally within the brain, elicit long-lasting neuroimmune responses. This happens through the transcription of immune-related genes and the activation of glial cells, specifically astrocytes and microglia. These cells are the principal immune mediators residing in the brain, and they respond to threats or signals by releasing molecules like cytokines and chemokines, which further drive inflammation. Crucially, neurons themselves also participate in mediating immune responses and express immune-related genes, highlighting a much more integrated view of brain function than we previously had.
Microglia seem particularly important here, the brain's resident macrophages.
They do. There's a new appreciation for how microglia directly communicate with neurons, influencing synaptic function and plasticity. The transition of microglia from a resting state to various reactive states is a diverse process with different functional outcomes. These reactive states may either be neuroprotective and help maintain healthy CNS function, or critically, they can trigger detrimental neuroinflammatory processes that contribute to the development and progression of psychiatric disorders, including AUD, as well as neurodegenerative diseases like Alzheimer's.
Does this offer new therapeutic possibilities?
It's incredibly promising. Drugs that specifically inhibit neuroimmune or pro-inflammatory signaling pathways have opened entirely new avenues for potential pharmacotherapies for AUD. These are currently being rigorously studied for their potential to reduce alcohol drinking, alleviate withdrawal symptoms, reduce craving, and perhaps even mitigate some of the cognitive deficits associated with chronic alcohol use. It represents a significant shift in our approach to understanding and treating addiction, moving beyond just neurotransmitters to consider the profound role of neuroinflammation.
Finally, rounding out the systemic impact, we absolutely must address cancers. You stated ethanol is unequivocally identified as a procarcinogen.
Yes, meaning it promotes the development of cancer. It significantly increases the risk of several types of cancers throughout the body. There's no ambiguity about this link.
Which specific cancers have the strongest link?
For instance, individuals who drink 50 grams of alcohol, which is approximately 3.5 standard drinks, or more daily, are at 2 to 3 times greater risk of developing cancers of the oral cavity, pharynx, throat, and larynx, voice box. And critically, if you add tobacco use to that level of alcohol consumption, these risks escalate exponentially, showing a dangerous synergistic effect. They multiply each other's harm.
What about other cancers? Colorectal, esophageal?
That same level of drinking 50 grams of ethanol or more daily is also associated with about a 1.5 times greater risk of developing colorectal cancer compared with non- or occasional drinkers. Alcohol use disorder is a major risk factor for esophageal squamous cell carcinoma, a specific type of esophageal cancer. And as we'll discuss more in our genetics section, having a genetic deficiency of the ALDH2 enzyme significantly increases this risk even further, especially in drinkers.
And liver and breast cancer.
AUD is a primary cause of liver cancer, particularly hepatocellular carcinoma, which often arises in the context of alcohol-related liver cirrhosis. For breast cancer, epidemiological studies consistently show a higher risk in women who are heavy drinkers. And alarmingly, increased risk is seen even at lower levels of consumption compared to some other cancers.
Does alcohol interfere with cancer treatment too?
Yes, that's a notable clinical complication. In cancer patients who also have AUD, ethanol can interfere with the metabolism of certain chemotherapeutic agents, potentially making the treatment less effective or more toxic.
What are the primary mechanisms driving this increased cancer risk?
The effects of acetaldehyde, which is the primary toxic metabolite of ethanol and a demonstrated group 1 carcinogen in animal models, are widely cited. Oxidative stress, caused by the production of damaging free radicals during alcohol metabolism, is another major factor. Additionally, growing evidence points to a crucial role for aberrant DNA methylation patterns and other epigenetic modifications. These are processes that affect gene expression, which genes get turned on or off without changing the underlying DNA sequence itself. These epigenetic changes are increasingly understood as key mechanisms in alcohol-induced cancer development and progression. It's really a multi-pronged attack on cellular integrity and genetic control systems.
Okay, now that we've thoroughly explored the pervasive systemic impact of ethanol across nearly every organ system, let's pivot to understanding its intergenerational impact, the unseen legacy it can leave, and then look towards the current and future horizons for treatment. A significant and truly tragic intergenerational impact is fetal alcohol spectrum disorders, or FASD. You said ethanol is tragically the most common teratogen in humans.
Yes, a teratogen is any agent that can cause birth defects, and ethanol holds that unfortunate distinction. It's critical to understand that ethanol, from a mother's blood, passes freely and unimpeded across the placenta to her developing baby through the umbilical cord. This means that the embryo or fetal blood ethanol concentrations will be virtually identical to the maternal levels, exposing the extremely vulnerable developing fetus to the same high toxic concentrations.
And children born to mothers who are heavy drinkers often display this recognizable pattern, fetal alcohol syndrome, FAS.
Yes, they display significant mental deficits and a common pattern of distinct physical abnormalities known collectively as FAS. The diagnosis of FAS is typically based on the rigorous observation of a triad of abnormalities associated with a confirmed history of prenatal ethanol exposure.
What's in that triad?
First, a cluster of distinctive craniofacial abnormalities, specific facial features. Second, clear central nervous system dysfunction, which can manifest as structural abnormalities visible on brain imaging or as functional impairments in cognition or behavior. And third, pre- or postnatal growth deficiencies, specifically in weight or height below expected norms, indicating overall compromised development.
But you mentioned fetal alcohol spectrum disorder. FASD is a broader term.
Exactly. FASD is actually an umbrella term. It's not a specific diagnostic term used by clinicians for a single condition, but rather a broad category that encompasses all of the disabilities and diagnoses caused by prenatal alcohol exposure. For example, children who don't meet all the stringent criteria for a full diagnosis of FAS may still show significant physical or mental deficits consistent with partial phenotypes. This includes conditions like partial FAS, alcohol-related neurodevelopmental disorder, ARND, which primarily involves cognitive and behavioral issues without the full facial features, and alcohol-related birth defects, ARBD, which involves specific organ system defects linked to prenatal alcohol exposure. The DSM-5 further characterizes neurobehavioral disorder associated with prenatal alcohol exposure as a specific condition linked to documented problems in thinking, behavior, and essential life skills.
What's the incidence rate? How common is this?
The incidence of full FAS is estimated to be about 0.5 to 2 per 1,000 live births in the general U.S. population. However, when you combine FAS, ARND, and ARBD under the FASD umbrella, the overall incidence is estimated to be at least 1% of live births, potentially higher in some populations. This makes it a surprisingly prevalent developmental disorder.
Which underscores the need for early intervention.
Absolutely. Early diagnosis and targeted treatment intervention are incredibly important for these children, as it can significantly improve their long-term outcomes and quality of life. Sadly, higher rates of FAS are observed in children born to African American and Native American women, highlighting significant health disparities that need addressing.
Is binge drinking during pregnancy particularly harmful?
Yes. Children born to mothers who engage in binge drinking during pregnancy often show particularly severe mental and behavioral deficits. This is likely due to the high peak blood ethanol concentrations experienced by the developing fetus during critical developmental periods, which are acutely toxic to migrating and differentiating neurons.
Can you describe the specific abnormalities seen in FAS, the facial features?
The characteristic craniofacial abnormalities are associated with maternal drinking, particularly in the first trimester, when facial structures are rapidly forming. They consist of microcephaly, a smaller than normal head circumference, shortened palpebral fissures, meaning narrower eye openings, a thin upper lip, a smooth philtrum, which is the vertical groove between the base of the nose and the border of the upper lip, it's flattened or absent, and sometimes epicanthal folds, a skin fold of the upper eyelid covering the inner corner of the eye.
And these facial features correlate with brain changes.
Yes, advanced magnetic resonance imaging, MRI studies, have actually demonstrated decreased volumes in critical brain regions, like the basal ganglia, the corpus callosum, which connects the two brain hemispheres, the cerebrum, the main part of the brain, and the cerebellum, involved in coordination. These structural brain abnormalities consistently correlate with the severity of the observed facial abnormalities, linking the external signs to internal neurological impact.
And the CNS dysfunction itself, what does that look like behaviorally?
The central nervous system dysfunction directly attributed to in utero ethanol exposure is wide-ranging and often debilitating throughout life. It includes hyperactivity, ADHD is common, significant attention deficits, general mental deficits, specific learning disabilities, impairments in language development, memory problems, motor skill disorders, and a higher risk for various psychiatric conditions like anxiety, depression, and impulse control disorders.
The cognitive impact sounds severe.
It is. The stark reality is that FAS is the #1 preventable cause of intellectual disability, cognitive deficits, and attention deficits in the Western world. Children afflicted consistently score significantly lower than their peers on a variety of IQ tests and adaptive functioning scales.
What about lower levels of drinking during pregnancy? Is there a safe level?
While the evidence is not yet entirely conclusive regarding lower levels of exposure, some studies have suggested that even moderate alcohol consumption, around 28 grams per day, or about 2 standard drinks, particularly in the second trimester, is correlated with impaired academic performance and executive function difficulties in children at age 6. This suggests a broader risk continuum than previously understood, where even seemingly moderate intake might have subtle but significant long-term consequences.
Does the mother's age play a role?
It might. Maternal age seems to be a factor. Pregnant women over age 30 who drink alcohol may, paradoxically, create greater risks to their children than do younger women who consume similar amounts of alcohol. The reasons aren't fully clear, but might involve age-related differences in metabolism, placental function, or cumulative environmental exposures.
And risk of miscarriage.
Yes, Additionally, the intake of high amounts of alcohol, particularly during the critical first trimester when organogenesis is occurring, greatly increases the chances of spontaneous abortion or miscarriage.
So, what is the absolute key recommendation for any professional advising someone about pregnancy and alcohol?
The key recommendation, derived from decades of research and clinical experience, is clear and unequivocal. Alcohol use is risky throughout the entirety of pregnancy, and there is absolutely no known safe amount, no safe time, and no safe type of alcohol. Current evidence-based recommendations from all major health organizations are to consume no alcohol whatsoever during pregnancy. The potential for irreversible harm to the developing child simply isn't worth any perceived benefit or risk. It's a message that needs constant reinforcement.
Okay, so given all this profound and widespread negative impact we've spent so much time detailing, it's almost paradoxical that ethanol actually has some crucial clinical uses.
It is paradoxical but true. For instance, in the acute treatment of poisoning by methanol or ethylene glycol found in antifreeze, while fompasol is generally the preferred first-line treatment due to its specificity and better safety profile, systemically administered ethanol is still used as an alternative or adjunctive therapy.
Remind us how that works again.
It acts at the alcohol dehydrogenase ADH enzyme to competitively inhibit the metabolism of methanol or ethylene glycol into their highly toxic byproducts, like formic acid or glycolate and oxalate. By saturating the ADH enzyme with ethanol, which it actually prefers metabolizing, you effectively slow down the production of these toxins, buying critical time for the body to excrete the unmetabolized poison or for other interventions like hemodialysis to work.
Are there other clinical uses? For pain?
Yes. Dehydrated, pure alcohol injected in close proximity to nerves or sympathetic ganglia is therapeutically used to relieve long-lasting, intractable pain related to conditions like trigeminal neuralgia, severe facial pain, pain from inoperable carcinoma, and other severe chronic pain syndromes where other treatments have failed. It essentially performs a chemical neurolysis, destroying the nerve fibers transmitting the pain signal.
So that sounds quite specific.
It is. Epidural, subarachnoid, and lumbar paravertebral injections of ethanol are also administered for specific types of inoperable pain. For example, lumbar paravertebral ethanol injections can destroy sympathetic ganglia, which are nerve clusters controlling blood vessel tone. This destruction causes vasodilation, which can provide significant pain relief and even promote the healing of lesions in patients suffering from severe peripheral vascular disease of the lower extremities. It's truly remarkable how a substance that causes so much harm can, in these very specific controlled clinical settings, be precisely deployed as a potent therapeutic agent.
Absolutely. Now let's delve into the incredibly complex realm of drug interactions with ethanol. This is a critical area for any medical professional, any pharmacist, any patient, really. There are literally hundreds of over-the-counter and prescription medications that can interact adversely with alcohol, leading to unpredictable and often dangerous outcomes.
It's a huge area of concern. One very common and concerning interaction involves aspirin or other non-steroidal anti-inflammatory drugs, NSAIDs like ibuprofen or naproxen. Ethanol significantly increases the risk of gastrointestinal bleeding and potentially liver damage when taken concurrently with these medications, essentially exacerbating their known side effects.
And the CNS depressant effects.
Due to potent synergistic effects in the central nervous system, extreme caution is necessary when administering sedatives like benzodiazepines, Valium, Xanax, or barbiturates, or even potent antihistamines to patients who have recently ingested heavy doses of ethanol or other CNS depressants. This combination can rapidly lead to severe respiratory depression, loss of consciousness, coma, and death.
What about implications for surgery and anesthesia?
It's complex and depends on whether the drinking is acute or chronic. Acute ethanol intoxication actually decreases the requirements for general anesthetics because ethanol itself is a CNS depressant. This is a critical point. Elective surgery should always be postponed in acutely intoxicated patients due to this altered anesthetic sensitivity and increased risk.
But chronic drinking has the opposite effect.
Exactly. Chronic ethanol drinking increases anesthetic requirements, largely due to pharmacodynamic cross-tolerance. The brain adapts to the chronic presence of ethanol and becomes less responsive to other CNS depressants, including anesthetics. This creates an additional layer of complication, particularly when using neuromuscular blockers, like sacchinylcholine, which has altered metabolism with liver dysfunction, and sedative anesthetic agents, like benzodiazepines, also affected by liver function, in patients with alcohol use disorder who may also present with compromised liver function. Anesthesia becomes much trickier.
We also have to consider complex pharmacokinetic interactions, which involve how alcohol affects the body's processing, the metabolism, and excretion of other drugs. How does acute ethanol affect other drugs?
Acute administration of ethanol generally inhibits the function of enzymes responsible for metabolizing a variety of different drugs. This includes commonly prescribed medications like codeine and morphine, making their effects stronger and potentially more dangerous, phenytoin, anti-seizure, some benzodiazepines, tolbutamide, an older diabetes drug, and warfarin, a blood thinner, among many others. This inhibition slows down the metabolism of these drugs, potentially leading to dangerously high levels in the bloodstream.
That statistic about opioids and alcohol was chilling.
It is. 1 in 5 prescription opioid deaths in the U.S. involves alcohol. Mixing these drugs dramatically increases the risk of fatal overdose, primarily through compounded respiratory depression. And because ethanol is itself a substrate for the CYP2E1 enzyme, any other drug that is also primarily metabolized by this specific CYP isozyme will be metabolized at a significantly slower rate in the presence of acute ethanol, compounding these interaction risks.
But again, chronic ethanol has the opposite pharmacokinetic effect.
In stark contrast, yes. The chronic administration of ethanol acts as an enzyme inducer, particularly powerfully inducing CYP2E1. This means it increases the rate of metabolism for other drugs that are substrates for CYP2E1 or other induced enzymes. This includes drugs like phenytoin, warfarin, making it less effective, increasing clotting risk, propranolol, a beta blocker, and certain benzodiazepines. This can lead to subtherapeutic drug levels if dosing isn't carefully adjusted and monitored in chronic drinkers.
And the interaction with acetaminophen, Tylenol.
That's a classic and very dangerous interaction. This increased CYP2E1 activity in heavy drinkers can convert even common, over-the-counter acetaminophen into a highly toxic metabolite, an APQI. This significantly exacerbates acetaminophen's potential hepatotoxicity, liver damage, making severe liver injury possible, even at what would normally be considered safe, or only moderately high doses. It's a critical warning for anyone who drinks heavily.
It's a truly complex and dynamic web of interactions that clinicians need to be acutely aware of. It requires a deep understanding of pharmacokinetics, pharmacodynamics, and crucially, obtaining an accurate individual patient history regarding alcohol use to avoid potentially catastrophic adverse drug events. Now, let's delve into comorbidity, the often high co-occurrence of alcohol use disorder with other psychiatric disorders.
This is a significant clinical reality and a major challenge in effective treatment. Patients diagnosed with a mood disorder like major depression or bipolar disorder, or an anxiety disorder like GAD or panic disorder, are about twice as likely to also suffer from a substance use disorder, including AUD and vice versa. The overlap is huge.
Which disorders are most commonly comorbid with AUD?
AUD is highly comorbid with other substance use disorders. Polysubstance use is common. Major depressive and bipolar disorders, certain phobias and anxiety disorders, and even complex personality disorders like antisocial and borderline personality disorders. AUD or other SUDs also frequently co-occur with severe mental illnesses like schizophrenia. This comorbidity often complicates diagnosis, treatment, and prognosis significantly.
Is there a shared biology driving this overlap?
Interestingly, emerging research suggests there might be. There appears to be a common neuroimmune link involving chronic inflammation and altered immune signaling pathways in the brain that has been identified among AUD and some of these comorbid psychiatric disorders, particularly depression and anxiety. This suggests a compelling and relatively new rationale for developing therapeutics that might simultaneously target these key neuroimmune pathways, offering potential new treatment avenues for these complex co-occurring conditions.
What about using antidepressants like SSRIs for AUD itself?
Generally, selective serotonin reuptake inhibitors, SSRIs, have not been shown to be universally effective treatments for AUD in individuals without a co-occurring mental health disorder like depression. However, SSRIs and other antidepressants can decrease alcohol intake when AUD and depression co-occur. This highlights a crucial point in integrated care. If problematic alcohol use seems to be occurring as a consequence of or is exacerbated by underlying depression, successfully treating that primary depression can, in turn, significantly decrease drinking behavior. You have to treat both.
Another significant and highly prevalent comorbidity is post-traumatic stress disorder, PTSD.
Extremely common comorbidity. Exposure to traumatic events and the debilitating long-term anxiogenic symptoms that often result are the cornerstone of PTSD. Classic symptoms include intrusion or re-experiencing the traumatic event, flashbacks, nightmares, avoidance of internal and external reminders of the trauma, negative changes in mood and cognition, persistent negative beliefs, detachment, inability to feel positive emotions, and heightened hyperarousal and reactivity, irritability, difficulty sleeping, exaggerated startle response.
And PTSD increases the risk for AUD.
Significantly, PTSD dramatically increases the risk of developing AUD or other substance use disorders, often as individuals attempt to self-medicate their profound distress and anxiety with alcohol or drugs. There's a remarkably high prevalence of comorbid AUD and PTSD in the U.S., particularly among veterans but also in the general population.
And having both makes things much worse.
Unsurprisingly, yes. A dual diagnosis profoundly exacerbates the symptoms of each disorder and significantly worsens the prognosis for recovery from either. This is not surprising, as AUD and PTSD share considerable overlap in the neural substrates, the brain regions and circuits involved, particularly stress and fear circuits like the amygdala and prefrontal cortex, and their underlying neuropathologies, including alterations in neurotransmitter systems and neuroinflammation.
How effective are current treatments for this dual diagnosis?
It's challenging. While SSRIs like sertraline and paroxetine are FDA approved for PTSD, surprisingly few rigorous studies have specifically examined their efficacy in patients who have both PTSD and AUD. One clinical trial found sertraline modestly improved PTSD symptoms and drinking measures, but only in a specific subset of patients who had early onset PTSD and less severe AUD, suggesting limited applicability across the board.
What about naltrexone, the AUD medication? Does it help PTSD?
Naltrexone, which is FDA approved for AUD, generally has modest effects on reducing alcohol consumption outcomes in this population, but does not appear to significantly improve PTSD symptoms itself. This clearly indicates a critical treatment gap. Randomized clinical trials are urgently needed to study potential drug combinations and integrated psychosocial therapies that can effectively address both of these complex, interconnected diseases simultaneously.
Shifting gears now to the very blueprint of addiction, alcohol use disorder and genetics. Like other complex trait disorders, think diabetes or heart disease, the development and progression of AUD are profoundly influenced by a multitude of interacting genetic and environmental factors.
Absolutely. Environmental factors include significant stressors like emotional, physical, or sexual abuse, early life adversity, as well as the specific drinking patterns prevalent within one's culture, family, and peer group. Social learning plays a role too.
But the genetic contribution is substantial.
Very substantial. Family studies, twin studies, and adoption studies consistently estimate the heritability of AUD to be remarkably high, generally ranging between 50% to 60%. This means that about half to a bit more than half of the variation in risk for developing AUD in the population can be attributed to genetic factors.
Among the numerous genetic variants identified, which ones are the most significant? You mentioned the metabolizing enzymes earlier.
Yes, among the genetic variants identified so far, the most significant and consistently replicated findings are indeed in the genes encoding the ethanol metabolizing enzymes, particularly alcohol dehydrogenase, ADH, and aldehyde dehydrogenase, ALDH. Linkage analyses, which trace disease inheritance in families, have powerfully shown that genes clustered specifically in the ADH region on chromosome 4 affect the risk for alcohol dependence.
Can you give an example, like the ADH1B variant?
Yes, the ADH1B2 variant is a great example. It's found with high frequencies in many East Asian populations and appears to offer a significant protective effect against developing AUD. This variant encodes an ADH enzyme that metabolizes ethanol much faster, leading to a rapid accumulation and transiently higher blood level of acetaldehyde. This rapid production of toxic acetaldehyde is associated with unpleasant flushing and other symptoms, leading to a lower risk for heavy drinking.
But you said paradoxically it increases cancer risk.
Yes, because acetaldehyde itself is a potent carcinogen. So, in those individuals with ADH1B2 who do manage to drink regularly despite the unpleasant effects, this faster metabolism to acetaldehyde is linked to a significantly higher risk for esophageal, head, and neck cancers.
Is there a similar variant in other populations?
Yes, the ADH1B3 single nucleotide polymorphism, found predominantly in individuals of African descent, encodes an enzyme that also metabolizes ethanol faster than the typical form, and is similarly associated with a lower incidence of AUD, likely through a similar protective mechanism involving more rapid acetaldehyde production.
Now, the story gets even more complex and critical with ALDH2, the enzyme that breaks down acetaldehyde.
Yes, ALDH2 is the most efficient isozyme in humans for the crucial second step of alcohol metabolism, converting that highly toxic ethanol-derived acetaldehyde into acetate, which is essentially harmless vinegar that can be used for energy.
And variations here are key to individual responses.
Absolutely critical. Because low levels of acetaldehyde, particularly for some individuals, can actually be perceived as subtly rewarding and stimulating, contributing to the positive effects of alcohol. However, as we've said, high blood levels of acetaldehyde produce distinctly toxic and highly aversive reactions: intense facial flushing, nausea, vomiting, diarrhea, palpitations, unstable blood pressure. Thus, genetic variation in ALDH2 activity can profoundly affect whether ethanol is experienced as primarily rewarding or intensely aversive, fundamentally shaping drinking behavior and risk.
And the ALDH2 variant is particularly impactful here.
Extremely impactful. This genetic variant encodes for an ALDH2 enzyme that is significantly impaired, almost inactive. It simply cannot efficiently convert acetaldehyde to acetate. Consequently, in individuals carrying this variant who drink alcohol, acetaldehyde, that group 1 carcinogen, can accumulate to dangerously toxic levels even after consuming small amounts of alcohol. This dramatically increases their risk of esophageal, head, and neck cancers, potentially by tenfold or more compared to those with the normal enzyme who drink similar amounts.
How common is this variant?
Approximately 10% of East Asians, people of Chinese, Japanese, Korean descent primarily, are homozygous for the ALDH22 variant, meaning they have 2 copies of this impaired gene. They typically develop severe adverse flushing reactions, nausea, and palpitations after consuming even 1 standard drink or less. Similar severe effects occur if anyone consumes ethanol while taking the ALDH inhibitor drug, disulfiram.
What about people with just 1 copy?
Heterozygotes? Almost 40% of East Asians are heterozygous for ALDH2, meaning they have 1 normal copy and 1 impaired copy. They typically experience noticeable facial flushing and enhanced sensitivity to alcohol, but they don't necessarily report the severely adverse responses seen in homozygous individuals. They might tolerate moderate drinking, but they still accumulate higher levels of acetaldehyde than people with 2 normal copies.
What's the crucial implication here for public health and clinical guidance?
The crucial implication is that ALDH2 deficiency, whether heterozygous or homozygous, poses a significantly increased risk of carcinogenesis, particularly alcohol-related upper digestive tract cancers. Therefore, those individuals who carry this variant and choose to drink should never dismiss what seem like mild responses to alcohol, such as facial flushing, as inconsequential. These are clear biological signals of impaired acetaldehyde metabolism and thus increased cancer risk that must be heeded and discussed with healthcare professionals.
Beyond these major enzyme variants, gene discovery efforts are looking broader, using genome-wide approaches.
Yes, absolutely. As gene discovery efforts continue to progress rapidly, utilizing advanced genomic techniques like genome-wide association studies, GWAS, on very large sample sizes, findings consistently show the polygenicity of alcohol use phenotypes. This means that alcohol use traits, including problematic use and dependence, are influenced by many, many genes, each contributing a small effect to the overall risk.
Where are these genes found? What systems do they affect?
These studies reveal an enrichment of candidate genes expressed in tissues from cortical, like the prefrontal cortex, and subcortical, like the striatum and amygdala, brain regions, known to be critically involved in AUD or other substance use disorders. Many classical neurotransmitters and neuromodulator system risk genes for AUD have been identified or confirmed in these large GWAS studies affecting GABA, glutamate, dopamine, opioid, serotonin systems, etc. Additionally, these studies highlight robust changes in risk associations in genes involved in brain stress response pathways and, increasingly, immune signaling and inflammatory pathways, reinforcing the neuroimmune links we discussed earlier.
Have these large studies found new risk genes?
Yes, a comprehensive genome-wide meta-analysis in individuals of European ancestry recently identified several new risk loci-specific locations on chromosomes associated with problematic alcohol use. It also found significant genetic correlations, meaning shared genetic influences, between problematic alcohol use and other substance use disorders, as well as various psychiatric traits, particularly major depressive disorder. This further solidifies the biological interconnectedness and shared genetic underpinnings of these often co-occurring conditions.
This detailed and evolving genetic blueprint truly underscored the immense complexity of AUD. It definitively shows it's far from just a matter of willpower or choice, but involves a deeply rooted neurobiological and genetic susceptibility interacting with environmental factors. Now let's turn to pharmacotherapies for alcohol use disorder, both the current options available and the future outlook. Despite the compelling need, you mentioned there's still a significant treatment gap in the U.S. for AUD compared to other prevalent psychiatric disorders.
Yes, it's a critical public health failure, frankly. The lifetime prevalence rate for AUD in the U.S. is estimated to be around 29%, meaning nearly 1 in 3 adults will experience it at some point. Yet despite the availability of several evidence-based treatment options, AUD often goes undiagnosed and, more strikingly, untreated. National surveys indicate that fewer than 1 in 10 individuals with a past year diagnosis of AUD actually receive any form of treatment, whether that's medication, counseling, or mutual help groups.
That's incredibly low.
It is, and it's incredibly concerning given that, as we've thoroughly explored throughout this deep dive, AUD is a systemic disease. It targets the central and peripheral nervous systems, the digestive tract, the heart and vascular system, the lungs, bone and skeletal muscle, and the endocrine and immune systems. AUD is unequivocally one of the leading causes of preventable morbidity and mortality in the United States and globally.
So what are the current FDA-approved medications? There are only a few.
Currently, yes, there are only 3 drugs specifically approved by the U.S. Food and Drug Administration, FDA, for the treatment of alcohol use disorder itself. Disulfiram, naltrexone, available in both oral and long-acting injectable forms, and acamprosate. Disulfiram, as we discussed, works by inhibiting ALDH and altering the pharmacokinetics of ethanol to create an aversive reaction. The other 2 agents, naltrexone and acamprosate, have primarily neurobiological mechanisms aimed at reducing craving and relapse.
How effective are they?
They have reasonable efficacy, with average effect sizes that are actually quite similar to those seen for commonly prescribed antidepressant drugs. However, despite this evidence, these medications are prescribed in less than 9% of patients diagnosed with AUD. This represents a stark and critical underutilization of available, effective treatments that could significantly improve outcomes.
And it's important to distinguish these AUD medications from treatments for acute withdrawal.
Yes, absolutely. For the management of acute alcohol withdrawal syndrome, particularly to manage severe symptoms like seizures and delirium tremens and prevent their progression, benzodiazepines remain the cornerstone treatment of choice due to their rapid action in dampening CNS hyperexcitability by enhancing GABAergic inhibition. Medications like diazepam Valium or chlordiazepoxide Librium are commonly used.
Okay, let's revisit disulfiram, brand name and abuse, in this treatment context. The first drug approved, but not first line today.
Correct. Disulfiram tetraethylfuran disulfide holds a unique place in history as the first drug approved specifically to treat alcohol abuse, but it is generally not considered a first-line treatment today due to its mechanism, potential side effects, and adherence challenges.
Remind us of the mechanism again. It inhibits ALDH.
Exactly. It inhibits aldehyde dehydrogenase, ALDH, and thereby rapidly increases the blood acetaldehyde concentration by 5 to 10 times the level measured when ethanol is administered alone. Disulfiram, or more likely its active metabolites, irreversibly inactivates both cytosolic and mitochondrial forms of ALDH, effectively shutting down that crucial second step of alcohol metabolism.
And the consequence is that intensely unpleasant acetaldehyde poisoning reaction if alcohol is consumed.
Precisely. Alcohol consumption by individuals previously treated with disulfiram gives rise to those marked signs and symptoms within just 5 to 10 minutes. At very low BECs, 5 to 10 mg%, mild effects are noted, but the severity increases markedly as the BEC reaches 50 mg%. If the patient attains a BEC of 125-150 mg%, loss of consciousness and even cardiovascular collapse can occur.
The symptoms again were flushing, throbbing headache, nausea, vomiting.
Yes. Hot, flushed, scarlet face, intense throbbing in head and neck, pulsating headache, respiratory difficulties, nausea, copious vomiting, sweating, intense thirst, chest pain, hypotension, low blood pressure, orthostatic syncope, fainting on standing, weakness, vertigo, blurred vision, and confusion. The facial flush is then typically replaced by pallor as blood pressure falls, potentially to shock levels. It's a severe reaction.
So its use requires careful supervision and high motivation.
Absolutely. The use of disulfiram requires careful medical supervision and thorough patient education about the risks. It should only be attempted in highly motivated patients who are genuinely committed to maintaining complete and total abstinence, as the deterrent effect is based purely on the fear of these severe adverse effects. Patients must also be meticulously educated to avoid all disguised forms of alcohol in sauces, vinegars, cough syrups, mouthwashes, even aftershave lotions or perfumes, as even trace amounts can trigger a reaction in some individuals.
And a major limitation is it doesn't reduce craving.
Correct. Disulfiram does not directly reduce the underlying alcohol craving. Its effectiveness is predicated entirely on the fear of the adverse effects, which unfortunately often leads to poor patient compliance. People simply stop taking it if they intend to drink.
What's the dosing and duration?
It should not be administered until the patient has abstained from alcohol for at least 12 hours, preferably longer. The FDA-approved dosage is typically 250 to 500 milligrams per day, usually taken in the morning. And critically, sensitization to alcohol may last as long as 14 days after the very last dose of disulfiram due to the slow rate of ALDH enzyme regeneration.
Are there contraindications or major interactions?
Yes. It should be used with extreme caution in patients with liver disease, and is absolutely contraindicated in those with significant cardiovascular disease due to the risk of severe hypotensive reactions during a potential alcohol challenge. From a drug interaction perspective, disulfiram or its metabolites can inhibit many enzymes containing sulfhydryl groups, including several hepatic CYPs. This interferes with the metabolism of numerous other drugs like phenytoin, chlordiazepoxide, barbiturates, warfarin, and others, requiring careful dose adjustments and monitoring.
Okay, moving to naltrexone. This is an opioid receptor antagonist approved for both AUD and opioid dependence.
Yes. Naltrexone, vivitrol, is approved for AUD in both oral and extended-release injectable forms, and it's also approved for the treatment of opioid use disorder, OUD, to prevent relapse.
How is it different from naloxone, Norcam?
Chemically related, but naltrexone has much higher oral bioavailability, meaning more is absorbed when taken by mouth, and has a significantly longer duration of action compared to naloxone, making it suitable for daily or monthly administration.
And its mechanism in AUD, it reduces the rewarding effects.
Its primary mechanism of action is thought to involve reducing endogenous opioid activity in the brain's mesolimbic reward pathways. Endogenous opioids, like endorphins, are released when drinking alcohol and contribute to its pleasurable effects. By blocking opioid receptors, primarily mu-opioid receptors, naltrexone is thought to blunt this opioid-mediated dopamine transmission, thereby reducing alcohol's reinforcing and rewarding effects, diminishing craving, and reducing the likelihood of returning to heavy drinking after a slip.
What's the typical dosing?
For the oral form, it's typically prescribed after no opioids have been taken for 7 to 10 days to avoid precipitated withdrawal at a dose of 50 milligrams per day. The extended-release intramuscular formulation, vivitrol, delivers 380 milligrams and is approved for monthly injection. This formulation is highly valuable as it significantly improves bioavailability and overcomes common problems with medication adherence associated with daily oral pills. It ensures continuous blockade for the month.
You said it's recommended as first line but still underutilized.
Yes. Despite its demonstrated efficacy and its recommendation as a first-line pharmacological treatment option by current American Psychiatric Association (APA) guidelines, naltrexone remains significantly underutilized in clinical practice.
How effective is it?
Multiple meta-analyses consistently show that oral naltrexone effectively reduces the risk of relapse to any drinking, and perhaps more importantly, significantly reduces the risk of returning to heavy or binge drinking. Both oral, 50 milligram a day, and injectable, 380 milligram monthly, naltrexone, have consistently demonstrated an increased likelihood of achieving no binge drinking days in various clinical trials, highlighting their practical benefit in reducing harmful drinking patterns.
What about side effects?
Naltrexone is generally well tolerated. The most common adverse effect is nausea, which is often mild and transient, tending to decrease over the first few weeks of treatment. Other potential side effects include headache, dizziness, anxiety, fatigue, and insomnia. Patients should also be monitored for the development or exacerbation of depression, although this is relatively uncommon.
Any concerns about liver toxicity?
Hepatotoxicity, liver damage, was a concern with very high doses used in early obesity trials, over 300 milligrams. But at the standard 50 milligram dose for AUD, significant liver injury is rare. However, the drug is still contraindicated in patients with acute liver failure or acute hepatitis and should be used with caution in patients with active liver disease, with baseline and periodic monitoring of liver function tests often recommended.
And the injectable form?
One potential concern with the intramuscular naltrexone injection is localized injection site reactions, such as pain, swelling, redness, or itching, which occur in a subset of patients but are usually mild to moderate.
And the opioid interaction is key.
Absolutely critical. Naltrexone blocks the effects of opioid analgesics like morphine, oxycodone, hydrocodone, meaning they won't work for pain relief. Furthermore, it can precipitate a severe and abrupt withdrawal syndrome in an opioid-dependent patient if they are not fully detoxified from opioids before starting naltrexone treatment, typically requiring 7-10 opioid-free days. Therefore, if opioids are needed for legitimate pain management in a patient actively taking naltrexone, much higher doses may be required to overcome the blockade, and this must be administered under careful medical supervision in a setting equipped to manage potential respiratory depression. Patients should carry a card indicating they are on naltrexone.
Okay, the third FDA-approved drug is acamprosate.
Yes, acamprosate, Campbell. It's also FDA approved specifically for the maintenance of abstinence from alcohol in patients with alcohol dependence who are abstinent at treatment initiation. It seems to work best in preventing relapse once someone has already stopped drinking.
What's its mechanism? Is it better understood now?
The exact mechanism of action has still not been fully elucidated, which is somewhat frustrating. However, it is thought to modulate the balance between excitatory glutamate neurotransmission, particularly at NMDA receptors, and inhibitory GABA neurotransmission. Chronic alcohol use disrupts this balance, leading to a hyperexcitable state during withdrawal. Acamprosate is hypothesized to help restore this equilibrium, perhaps by reducing glutamate activity and potentially enhancing GABA activity, thereby reducing the protracted withdrawal symptoms like anxiety, insomnia, and dysphoria that can contribute to relapse.
How well tolerated is it?
Acamprosate is generally very well tolerated. The main side effect reported more often than placebo is diarrhea, which is usually mild to moderate and often resolves with continued use. Other side effects are relatively uncommon.
And its efficacy?
A meta-analysis of randomized clinical trials show that acamprosate is associated with a reduced risk of returning to any drinking in patients who are already abstinent when starting the medication, supporting its role in maintaining sobriety. However, unlike naltrexone, it does not appear to significantly reduce the likelihood of heavy or binge drinking in those individuals who do relapse to some drinking.
What's the dosing like?
The FDA-approved dose is substantial, 1998 milligrams per day, which is typically administered as two 333 milligrams tablets taken 3 times daily, totaling 6 tablets a day. This dosing frequency, unfortunately, can significantly limit patient compliance compared to once-daily or monthly options.
Any major contraindication?
Yes, acamprosate is primarily eliminated by the kidneys unchanged. Therefore, it is contraindicated in patients with severe renal failure, creatinine clearance 30 LMN, and requires dose adjustment in those with moderate renal impairment.
So those are the 3 FDA-approved options, but you mentioned other drugs with repurposing potential, used elsewhere, or showing promise.
Yes, there are several other medications being studied or used off-label in the U.S. or approved in other countries that show potential for treating AUD.
Like baclofen. You said that's a muscle relaxant.
Right. Baclofen is a GABA receptor agonist, primarily used as a skeletal muscle relaxant to reduce spasticity in conditions like multiple sclerosis or spinal cord injury. Interestingly, it is approved specifically to treat AUD in France, particularly indicated for use in patients who haven't responded well to other treatments.
Any risks or downsides?
There is an increased risk of sedation, dizziness, and confusion, especially when combining baclofen with ongoing alcohol use, which is a key clinical consideration. In a meta-analysis of randomized clinical trials, baclofen was associated with a delay in return to drinking and a greater likelihood of achieving abstinence, particularly in those individuals who had higher levels of daily alcohol use at baseline. However, overall, the evidence remains somewhat uncertain regarding its widespread use, particularly as a first-line treatment, and results across studies have been mixed. More research is needed.
What about nalmefene, an analog of naltrexone?
Yes, nalmefene is chemically similar to naltrexone. It acts as a mu and delta opioid receptor antagonist, but also has partial agonist activity at kappa opioid receptors, which might differentiate its effects somewhat. Compared with naltrexone, nalmefene generally has a longer half-life, potentially greater bioavailability, and possibly the decreased risk of liver toxicity, although direct comparisons are limited.
Is it used differently?
Yes, the European Medicines Agency, EMA, has recommended nalmefene for a novel indication, as needed use, typically 18 milligrams taken 1 to 2 hours before anticipated drinking, specifically to reduce heavy drinking, rather than aiming for complete abstinence initially. This targeted harm reduction approach may be beneficial in high-risk situations, or for problem drinkers who are not ready or willing to commit to daily medication or complete abstinence but want to cut down.
How effective is that approach?
A meta-analysis of randomized clinical trials focusing on this reduction goal showed that nalmefene was associated with a slight but statistically significant reduction in the number of heavy drinking days and in total alcohol consumption over a 6-month period compared to placebo. It offers another potential strategy, particularly for harm reduction.
Gabapentin. We hear a lot about its off-label uses. How does it fit in for AUD?
Gabapentin is an anticonvulsant and a structural analog of the neurotransmitter GABA, although it doesn't act directly on GABA receptors. It primarily inhibits the ADI1 subunit of voltage-gated calcium channels, which modulates neurotransmitter release. It's widely used off-label for neuropathic pain, anxiety disorders, restless leg syndrome, and other conditions.
Then for AUD.
Current APA guidelines suggest considering its use to treat AUD after first trying naltrexone or acamprosate, so more as a second-line option. In one well-regarded clinical trial, gabapentin, particularly at higher doses, for example 1800 mg a day, significantly increased the rate of abstinence and effectively prevented relapse to heavy drinking compared to placebo. Gabapentin is also associated with decreased alcohol craving and is frequently used off-label to treat mild to moderate alcohol withdrawal symptoms, possibly making the transition to abstinence easier.
What about topiramate, another anticonvulsant?
Yes, topiramate, Topomax, is an anticonvulsant that has multiple mechanisms of action, including modulating voltage-gated sodium channels and enhancing GABA activity while reducing glutamate activity. It is FDA approved for seizure disorders and migraine prevention, and is also used off-label, sometimes in combination with phentermine, as an adjunct therapy for chronic weight management.
And its role in AUD.
Similar to gabapentin, current APA guidelines suggest using topiramate as a second-line treatment option for AUD, typically after trying naltrexone or acamprosate. A meta-analysis of randomized clinical trials showed topiramate is associated with a greater number of abstinent days and a reduced number of heavy drinking days compared to placebo. However, it can have more side effects than some other options, notably paresthesia, tingling sensations often in hands and feet, and dysgeusia, altered sense of taste, cognitive slowing, brain fog, and a risk of kidney stones, which can limit its tolerability for some patients.
Sodium oxybate, that's GHB. Isn't there concern about abuse?
Yes, sodium oxybate is the sodium salt of dihydroxybutyric acid, or GHB. It is FDA approved under strict RUNS programs to treat cataplexy and excessive daytime sleepiness and narcolepsy. Interestingly, it is approved in Italy and Austria specifically to prevent relapse and to treat alcohol withdrawal syndrome.
How is it thought to work?
It's structurally similar to GABA and is thought to act by mimicking some of the effects of ethanol at GABA and GABA receptors. It also increases dopamine levels in the mesocortical limbic circuitry, which may contribute to its ability to reduce craving and withdrawal symptoms. Because GHB itself is a known recreational drug of abuse, there has understandably been significant concern regarding its abuse potential and dangerous pharmacodynamic interactions with alcohol if used concurrently. However, clinical experience in Europe suggests this has not been a major issue in carefully selected patients without polydrug use or severe psychiatric comorbidities when used under strict medical supervision for AUD treatment. Its use remains controversial and highly restricted elsewhere.
Are there other compounds actively being investigated?
Yes, there are quite a few. Varenicline, Chantix, which is FDA approved for smoking cessation, also shows promise in reducing craving and alcohol consumption in some studies, possibly due to its effects on nicotinic acetylcholine receptors, which are also involved in alcohol reward. Varenicline acts as a partial agonist at R4-2 and other subtypes of NACHNSRs. Other compounds under investigation for the treatment of AUD, potentially for specific subgroups of patients, include aripiprazole, or Abilify, a dopamine receptor partial agonist, ifenprodil, an antagonist of a specific subtype of NMDA glutamate receptor, GLON2B, and the UDA1 adrenergic receptor antagonists like prazosin and doxosin, which target stress-related pathways.
And targeting inflammation.
Yes, drugs that specifically target immune and inflammatory pathways are also being actively studied for their potential to treat AUD, building on that neuroimmune research. For example, apremilast, Otezla, an inhibitor of phosphodiesterase type 4, PDE4, and an anti-inflammatory drug approved to treat psoriasis and psoriatic arthritis, showed promise in decreasing alcohol drinking in a human laboratory study.
These are addressing sleep issues.
Right. Lastly, suvorexant, Belsomra, an antagonist of OX1 and OX2 orexin receptors that is used to treat insomnia, is being investigated to see if it can reduce relapse drinking, potentially by treating the significant and common sleep disruptions found in AUD and early recovery, which are known triggers for relapse. It highlights an indirect but potentially crucial therapeutic strategy.
So when we consider the overall treatment outlook for alcohol use disorder, it's clear there's still that significant gap you mentioned in the availability and widespread utilization of pharmacotherapies compared with other prevalent psychiatric disorders like depression.
Absolutely. In the U.S., fewer than 1 in 10 individuals with past-year diagnosis of AUD receive any form of treatment. This is a profound public health concern that needs urgent attention.
And this treatment gap is particularly alarming because, as we've spent this entire deep dive exploring, AUD is not merely a behavioral issue, it is a profound systemic disease. It targets the central and peripheral nervous systems, the digestive tract, the heart and vascular system, the lungs, bone and skeletal muscle, and the endocrine and immune systems. It is unequivocally one of the leading causes of preventable morbidity and mortality globally. Effective treatment isn't just desirable, it's a moral and economic imperative.
And despite the overall modest effect sizes of the currently available pharmacological agents compared to, say, antibiotics for infection, they do demonstrably benefit some patients significantly, often beyond what psychosocial treatment alone can accomplish.
This is a crucial point for clinicians. These medications are valuable tools that should be integrated into comprehensive care plans, not seen as a last resort.
So there's a call to action for clinicians here, definitely. Clinicians across all specialties are urged to address this immense public health burden by significantly increasing routine screening measures for AUD, like using the ALUD ITC or single-item screeners, and then actively discussing evidence-based treatments, both pharmacological and psychosocial, like CBT, motivational interviewing, mutual help groups, for patients who meet the diagnostic criteria for AUD. Open, non-judgmental conversations are key.
And screening for comorbidities is vital too.
Absolutely critical. Screening for other comorbid psychiatric illnesses, depression, anxiety, PTSD, etc., and other substance use disorders in individuals with AUD is essential, as integrated treatment for these co-occurring conditions often leads to much better overall outcomes. You have to treat the whole person.
And ideally, treatment should start earlier.
Yes. As with any complex polygenic disease like diabetes or hypertension, the ultimate goal should be to initiate treatment earlier in the disease course, ideally before a prolonged history of heavy problematic use leads to severe and potentially irreversible neurobiological damage or inflammatory insults to organ systems. Early intervention is key.
The treatment goals themselves are also evolving, aren't they? Abstinence isn't always the only goal now.
That's right. While complete abstinence has traditionally been the singular main goal of AUD treatment and remains the safest goal for many, there's increasing recognition that reducing risky drinking behavior, such as significantly decreasing the number of heavy drinking days or binge drinking days per month, may also be a valid and highly beneficial treatment outcome for some patients, particularly those not ready or able to commit to immediate abstinence. Evidence for this harm reduction approach comes, in part, from patients in clinical trials who consistently report that their alcohol-related problems, health, social, legal, directly correlate with their number of days of heavy drinking. Reducing heavy drinking reduces harm.
What about future research? What tools are being used?
Future research will continue to leverage powerful new tools, such as combining advanced omics approaches like transcriptomics, studying gene expression patterns, with sophisticated computational methods, like machine learning and network analysis. The goal is to identify existing FDA-approved drugs, originally developed for other conditions, that might be effectively repurposed to target the specific dysregulated genes and biological pathways identified in AUD. This drug repurposing strategy can potentially accelerate the development of new treatments much faster than traditional drug discovery.
So the overall goal remains clear.
Yes, identifying improved and more personalized pharmacotherapies based on underlying biology or genetics, and critically, broadening access to comprehensive evidence-based treatment for all who need it. These are major overarching goals in the ongoing fight against this complex, pervasive, and devastating systemic disease.
We've truly taken a deep dive today, haven't we, into the incredibly multifaceted world of ethanol. We've dissected it from its ancient roots in human history right through to its modern complexities as a major public health challenge. We've uncovered its profound and often insidious impact on nearly every single system in the human body. We've explored its intricate, sometimes challenging, metabolic pathways, and we've examined the ongoing efforts to diagnose and treat alcohol use disorder, including the cutting edge of pharmacology, genetics, and neuroimmune research.
You now possess, hopefully, a comprehensive, truly elite professional-level understanding of this incredibly prevalent substance, recognizing not just what it does at a cellular and systemic level, but why it matters so much for public health and individual well-being, and how scientists and clinicians are working tirelessly, using ever more sophisticated tools to address its complex challenges. You're not just informed now. You're truly well-versed in a topic that affects millions and millions of people globally.
So, considering how deeply embedded alcohol is in human history and culture, stretching back millennia, and yet, considering the profound systemic and often intergenerational adverse effects we've discussed in such detail today, what does this deep dive suggest to you, our listener, about the future of public health policy, the ongoing challenge of balancing personal choice with biological predisposition and societal impact, and perhaps our evolving understanding of addiction itself as a complex brain disease?